Hold the clear flashback chamber with thumb and fingers on opposite sides behind the finger flanges so that needle flash is clearly visible. The finger flanges are designed to minimize touch contamination. B. Brown's proprietary universal bevel is a sharp needle that provides flexibility of insertion angles. The universal bevel creates a V-shaped tricuspid incision, resulting in a flexible pathway for easy and smooth catheter insertion. The result is greater comfort for patients and easier insertion for clinicians. The double flashback technology improves first stick success through quick visualization of both the needle flash and the catheter flash. Here's how the double flashback technology delivers this benefit. Upon insertion, the first flashback of blood, needle flash, is visible in the clear flashback chamber, confirming the needle tip is in the vein. Then the entire device, catheter and needle, is lowered and advanced slightly into the vein. Using the push-off plate on the catheter hub, the catheter is advanced forward, off the needle, into the vein. A second flashback, catheter flash, occurs between the catheter and the needle, confirming that the catheter is successfully in the vein. Once the catheter is advanced completely, the needle is withdrawn straight out of the hub in a controlled and continuous motion. The passive safety shield engages as the needle tip passes through the catheter hub. It deploys automatically and permanently shields the needle tip. This passive safety feature cannot be bypassed and is designed to protect against needle stick injuries. As the needle is withdrawn, the multi-access septum closes, controlling the flow of blood from the catheter hub. When a Luer connection is made, the multi-access septum opens, allowing flow in and out of the catheter. When the Luer accessory device is disconnected, the multi-access septum closes. The septum works multiple times to help prevent contact with the patient's blood. The integrated stabilization platform is designed to improve catheter stability and minimize movement within the vessel. The unique vein entry angle of the catheter hub is designed to prevent catheter kinking, and the ergonomic hub design allows for easy and aseptic connection of devices while keeping the Luer connection off the patient's skin. The stabilization platform allows for easy catheter securement and is designed to minimize catheter movement in the vessel. The stabilization platform's unique shape allows visualization of the insertion site. The removable vented flash plug provides additional versatility. It can be loosened to speed blood return during catheter insertion. The flash plug can be replaced with a syringe or blood collection access device. The B. Brown Intracan Safety 3 closed IV catheter, providing safe and efficient IV access from start to finish. B. Brown Intracan Safety 3 closed IV catheter, making IV access safe and efficient from start to finish. Hold the clear flashback chamber with thumb and fingers on opposite sides behind the finger flanges so that needle flash is clearly visible. The finger flanges are designed to minimize touch contamination. B. Brown's proprietary universal bevel is a sharp needle that provides flexibility of insertion angles. The universal bevel creates a V-shaped tricuspid incision, resulting in a flexible pathway for easy and smooth catheter insertion. The result is greater comfort for patients and easier insertion for clinicians. The double flashback technology improves first stick success through quick visualization of both the needle flash and the catheter flash. Here's how the double flashback technology delivers this benefit. Upon insertion, the first flashback of blood, needle flash, is visible in the clear flashback chamber, confirming the needle tip is in the vein. Then the entire device, catheter and needle, is lowered and advanced slightly into the vein. Using the push-off plate on the catheter hub, the catheter is advanced forward, off the needle, into the vein. A second flashback, catheter flash, occurs between the catheter and the needle, confirming that the catheter is successfully in the vein. Once the catheter is advanced completely, the needle is withdrawn straight out of the hub in a controlled and continuous motion. The passive safety shield engages as the needle tip passes through the catheter hub. It deploys automatically and permanently shields the needle tip. This passive safety feature cannot be bypassed and is designed to protect against needle stick injuries. As the needle is withdrawn, the multi-access septum closes, controlling the flow of blood from the catheter hub. When a Luer connection is made, the multi-access septum opens, allowing flow in and out of the catheter. When a Luer accessory device is disconnected, the multi-access septum closes. The septum works multiple times to help prevent contact with the patient's blood. The integrated stabilization platform is designed to improve catheter stability and minimize movement within the vessel. The unique vein entry angle of the catheter hub is designed to prevent catheter kinking, and the ergonomic hub design allows for easy and aseptic connection of devices while keeping the Luer connection off the patient's skin. The stabilization platform allows for easy catheter securement and is designed to minimize catheter movement in the vessel. The stabilization platform's unique shape allows visualization of the insertion site. The removable vented flash plug provides additional versatility. It can be loosened to speed blood return during catheter insertion. The flash plug can be replaced with a syringe or blood collection access device. The B. Brown Intracan Safety 3 closed IV catheter, providing safe and efficient IV access from start to finish.
for our convention to formally start, may we ask all our participants to kindly type in the chat box your name and institution so we can acknowledge you and welcome you in our program today. Thank you.
What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. Half the world is sleeping, half the world's awake, half can hear their hearts beat, half just hear them break. I am but a traveler in most everywhere. Ask me what you want to know. What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. I have been to sorrow, I have been to bliss. Where I'll be tomorrow, I can only guess. Through the darkest desert, through the deepest snow, forward, always forward I go. What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. Forward, always forward. Onward, always up. Catching every drop of hope in my empty cup. What a journey it has been. In the end is not I can see a better day. I won't let the darkness in. What a journey it has been. What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. Forward, always forward. Onward, always up. Catching every drop of hope in my empty cup. What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. What a journey it has been. In the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. What a journey it has been.
Quickly acknowledge the participants from all over the world. Hello to our attendees from Rizal Medical Center.
Attendees or participants from Davao Doctors College.
Amang Rodriguez Memorial Medical Center.
How about those from Cotabato Regional and Medical Center?
From UNP Hospital, Vigan City.
Good morning po sa mga kapitbahay namin sa Capital Medical Center.
From St. Vincent General Hospital, Cebu.
From Bicol Medical Center.
From Zamboanga del Norte Medical Center.
Punta naman tayo sa Marawi, sa Amay Pakpak Medical Center.
From Cagayan Valley Medical Center.
Also, our delegates from Baguio General Hospital and Medical Center.
And from Misamis University Medical Center.
Also, those from Western Visayas Medical Center, Iloilo.
Our attendees from Priory Hospital, North London.
Going international pala tayo.
Yes.
Also, from Waikato DHB, New Zealand.
From Montelao Country Hospital, Lanao del Norte.
Again, good morning sa inyo delegates and welcome sa ating convention.
Yes, and we have many more. Naikot na natin ang buong mundo. We also have delegates from Indonesia, Kuwait. Hello, thank you for joining us.
Meron din tayo sa Tuguegarao, sa Nueva Vizcaya,
Yes.
sa Iligan, sa Benguet, ang dami.
Oh my gosh, it warms our heart that you give us your time to join us today. And we would also like to acknowledge the virtual presence of our former president, Ma'am Felicissima Romero, and our founder, the founder of Scvnppi, Dr. Maria Linda Buhat. Thank you, ma'am, for joining
Good
us.
morning po sa inyo.
Good morning. Good morning. Let us begin. The Society of Cardiovascular Nurse Practitioners of the Philippines, Incorporated, would like to welcome you all to the 21st Annual Convention with a theme spanning the spectrum from prevention and management of cardiovascular diseases. I am Sheena Aster Importante, and joining us today is Mr. Kevin Bryce Fetalvero, who will be your host and moderator for today's convention. For the house rules, first, kindly join early so you won't miss out on anything. Stay focused on the discussion. Cut off any background noise. Turn off your cameras. Dress appropriately, and don't forget to mute your mic.
Good morning, Sheena, and good morning to all our participants. We will now officially start our program with an invocation, the Philippine National Anthem, and the Scvnppi hymn. This will be followed by the video presentation of the Cardiovascular Nurse Practitioner Program graduates and the Board of Directors of the Scvnppi.
Our dear Almighty Father, we express our sincere gratitude for the gift of another day. We ask forgiveness for our sins, for which we lay our regrets and sorrows. Thank you for your overflowing and unending patience, kindness, and love that you shower us every day of our lives. Today, as we gather for this special event, we humbly seek your divine providence to help us share your grace to others. Help us engage in meaningful discussions by giving us wisdom, understanding, and guidance. Help us learn and grow and love one another so that we can become better children of yours. Amen.
ang pambansang awit ng Pilipinas. Kayang magiliw, helas na sinakalan, alam ng puso, sa dikit mo'y buhay. Lupang hinirang, kuya ka ng magiting, sa manlulupin, di ka pasisigil, sa nanagang tutok sa simoy at sa langit ng pagaw, ay hinatang tulang awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nag-iibig, ang bituin at taro niya kailan pa may magdidinig. Luman ang araw ng walhaging pagsinta, buhay langit sa piling mo. Ang hindi kaya naman ay hanapin, ang mamatay ng dahil sa'yo.
The Scvnppi is the leading specialty organization committed in advancing cardiovascular nursing, upholding the highest standard of nursing practice, recognized globally. The Scvnppi is committed to advance cardiovascular nursing practice through the application of standards, education, research, and linkages in order to promote the quality of cardiovascular health of all the people. The Scvnppi is the leading specialty organization committed in advancing cardiovascular nursing, upholding the highest standard of nursing practice, recognized globally. The Scvnppi is committed to advance cardiovascular nursing practice through the application of standards, education, research, and linkages in order to promote the quality of cardiovascular health of all the people. The Scvnppi.
Before we further continue with today's program, I'd like to acknowledge the virtual presence of our delegates from Cotabato Regional and Medical Center and St. Vincent HSH's Hospital from Wisconsin, United States. And of course, delegates from Philippine Heart Center. Welcome.
Welcome mga kapatid. Good morning.
And now to officially open our convention, we would like to call on Ms. Janine L. Comendador, RNDDN, President of the Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated, to give her welcoming remarks and to introduce our keynote speaker for today. Let us give her a warm virtual applause.
Distinguished guests, exemplary nurse leaders, participants, ladies and gentlemen, naimbag abigat, marhay na aga, maayong aga, maupay nga aga, maayong buntag, magandang umaga, good morning. Welcome to the 21st Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated Annual Convention with the theme, Spanning Spectrum from Prevention and Management of Cardiovascular Diseases. I would like to congratulate this year's organizing committee, as well as thank our sponsors, as with their combined efforts and overwhelming support, this event will not be able to reach its fruition. Cardiovascular disease remains to be the #1 cause of mortality globally, and more than 75% of which comes from low and middle income countries. Nurses play a vital role in health promotion and disease prevention in collaboration with other health care team members. This is also aligned with the Universal Health Care Act, Republic Act 11-22-3, for the nation's healthcare system to be accessible to all. This law further emphasized the role of nurses in primary health care. The range of roles that nurses play in taking care of our cardiovascular patients, spanning from pediatric to adulthood nursing, in various clinical settings, as well as in the development of clinical pathways, encompasses from prevention up to rehabilitation towards improving healthcare outcomes. These will all be highlighted in this convention. May this event foster new learnings, network building, and strengthen healthcare collaboration among us. With this, as the president of the society, I now declare this convention open. To inspire us to consistently strive for excellence, we have invited a speaker, well-honed and tested by time and experience as a nurse. With more than 40 years of practice as a cardiovascular and neurointensive care nurse, her contribution to critical care nursing is rightfully to be recognized. She had practiced the profession both locally in St. Luke's Medical Center and Philippine Heart Center, and internationally, King Faisal Specialist Hospital and Research Center in Saudi, New Dubai Hospital in UAE, St. Barnabas Medical Center in New Jersey, and in Guam Medical Regional City, to name. Started as an ER staff nurse, she occupied various positions such as charge nurse, senior charge nurse, nurse supervisor, and nurse educator as she rose from the ranks. She is one resilient lady who never had any qualms to start from the bottom and rose to the top in every institution she entered. She had been instrumental in helping novice nurses in transitioning to their professional role. A certified critical care nurse, an AHA, basic life support instructor, a formidable nurse educator. Ladies and gentlemen, please join me in giving our warmest virtual welcome to our distinguished keynote speaker, Ms. Scvnppi Diestro.
Good day, everyone. Cardiology as a specialty was introduced in the Philippines with a formal organization with the Philippine Heart Association in March 26, 1952. Under the initiative and leadership of Dr. Mariano Alimorong, our first president, Dr. Barcelona as vice president, and our very own Antonio Samya as secretary. The vision to provide specialized medical services for Filipinos suffering from heart ailment and allied diseases was shared with our national leaders. And eventually, our very own Philippine Heart Center was established in February 14, 1975. There was a call to take part in this great endeavor, and a group of experienced nurses, fresh from cardiovascular training in the States, responded to the call. We shared our expertise to various clinical areas of specialty, to mention coronary care unit, intensive care unit, operating theater, cardiac rehab, and other heart stations. The job was overwhelming but challenging. All efforts directed toward the common goal to provide the best quality care to our patients with cardiovascular disease. Over the years, Philippine Heart Center continues to be a leader in cardiovascular care, but the reality that cardiovascular disease is still #1 cause of mortality cannot be ignored. There is a need to revisit our strategies and strengthen what works best in this digital era where the use of technology is of great advantage. Talking about the spectrum of prevention of cardiovascular disease, I could think of one strategy, and that is empowerment. It should start with the patient. Patient empowerment in general is a practice that encourages patients to become more active, involved in services offered by the healthcare provider. And why does it matter? The purpose of patient empowerment is to help patients improve their self-awareness, adherence to the treatment regimen, and eventually improve their health outcome. According to European Patient Forum, patient empowerment includes 5 aspects. 1, self-efficacy. It relates to the feeling of control and patient willingness to tackle new tasks. Number 2, self-awareness. It's a state of being aware of the current health situation. Number 3 is confidence. The patient's willingness to make a decision about his health. Number 4 is coping skills. Skills necessary for patients to deal with their health condition. Number 5 is health literacy. One of the most important aspects of empowerment, as it entails the patient's level of understanding of his illness. How can you empower your patients? Empowered patients want and need consistent quality communications with their providers. I would like to emphasize the word with. These interactions involves a two-way dialogue, but not a lecture from an all-knowing physician. A patient voice has to be heard and understood by their providers. Involve them in their plan of care. Patient engagement is a must, so that your goal for the patient to have an active role in their treatment process can be achieved. This is a digital era. Various platforms are available. Videos, virtual presentations are available. Almost all of us in this population of ours owns a cell phone. That could be our tool in educating our patients. What about our family members and caregivers? This will greatly help patients who has chronic illnesses that needs long-term care. We have to empower them. Like for example, for stroke patients, behavioral changes may be present and the caregiver must understand the reason why. A simple feeding is challenging to them. It is a recommendation that while in the hospital, we identify the caregivers and let them participate in simple tasks under our own supervision, and eventually able to develop that autonomy and felt empowered to be a part of the clinical care. Community empowerment is also very important. Community-based nurses and health workers play a vital role in cardiovascular disease in prevention. How? They enhance the effectiveness of programs to influence individual and population's lifestyle. 2, awareness of high-risk factors which could be modified. 3, adherence to recommendations. And 4, involvement in the program evaluation. Living in the community gives them an advantage, a cultural advantage, to address economic, psychosocial, and behavioral factors where appropriate interventions can be planned and implemented. We nurses, we have the knowledge and power to reach out to our patients. Let them feel they're not alone, and those emotional barriers can be overcome. A healthy relationship binded with trust and sincerity can bring about changes, insights, and perceptions. Overall, let me conclude that prevention of heart disease is not a responsibility of one, but all. The call can be heard, and our response is much desired. Thank you.
Thank you, Mrs. Evelyn Diastro, for that very inspiring and empowering speech. Dapat talaga in-involve natin yung patients natin sa ating plan of care. It's not just the doctors, hindi lang tayo mga nurses, hindi lang yung mga artists natin. Also, kasama din natin yung mga patients natin para din sa pagaling nila. And with that, at this point, we would like to present the Certificate of Appreciation to Mrs. Diastro. The Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated would like to award the Certificate of Appreciation to Ma'am Evelyn P. Diastro, RN, CCRN, in grateful recognition of her invaluable contribution as keynote speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th day of May in the year of our Lord 2002. Signed, Jesus Ferdinand B. Peralta, RN, Chairperson of the Scvnppi 21st Annual Convention, and Janine L. Comendador, RN, DBM, President, Scvnppi.
Again, thank you, Ma'am Diastro.
Thank you, ma'am.
At this part of the program, we will now proceed with the lecture presentation for the morning session. We will have 2 interesting topics to be discussed. Please allow me to introduce our first speaker this morning. Our speaker is Nurse 4 from Mariano Marcos Memorial Hospital and Medical Center. He was hailed Most Outstanding Employee for the year 2014, and he was able to finish his Master of Arts in Nursing at Mariano State University last 2018. He was awarded 3rd place in the 2019 Regional Health Conference under the poster presentation category. He is also a certified level 3 cardiovascular nurse under the DOH Nurse Certification Program. Ladies and gentlemen, to discuss about the best practices on the role of nurses in the management of cardiovascular diseases, Let us all welcome Mr. Richard Irvin M. Bismonte, RN Man. Let us give him a virtual round of applause.
Hello, everyone. Hello, everyone. To the officers of the Society of Cardiovascular Nurse Practitioners, to the host of this event, and also to our participant, magandang araw po sa inyo. Let me share to you way back 2019, when we had an opportunity with my colleague to be sent by our institution for a training in the Philippine Heart Center. At first, of course, we asked, what is this training all about? And they responded that this is a cardiovascular catheterization laboratory training for allied health professionals. So we say, so together with my colleague, we have a zero idea if what is this training all about. We don't know what is the role of nurses. So I am privileged to share with you a discussion to a specialty that I chose to take, which is cardiovascular cath lab nursing. So what is your life? What is a life of a cardiac nurse? Are we significant? Am I significant inside the cath lab room? My objectives for this lecture is to define a registered nurse specializing in cardiac cath lab, describe qualification and skills of a cardiac cath lab nurse. Third, recognize the roles and responsibilities of a nurse in a cardiac cath lab. Foresee the challenges of being a cardiac cath lab nurse. And lastly, identify the best practices or significance of the role. So let me show to you what it looks like inside the catheterization laboratory unit. So it is a specialized unit that uses radiologic guidance in the performance of various procedures in the diagnosis of certain diseases and eventual introduction of administration of therapeutic intervention. What you are seeing in the screen is our procedure room. You can see the C-arm. So basically, this is where our procedure is conducted. So if we say catheterization, it is the intervention and passage of small plastic tubes, which is a long catheters and various catheters, into the arteries and veins of the heart to obtain X-ray pictures, which is commonly known as your angiography, of coronary arteries and cardiac chambers, and also to measure pressures in the heart, which are the hemodynamic status of your patient. Indications for catheterization is used to identify structural cardiac diseases such as atherosclerotic artery disease, abnormalities of your heart muscle, it could be infarction or cardiomyopathy, and valvular or congenital heart abnormalities. Let me show to you another part of the catheterization laboratory, which is the control room. This is where the images are processed and reviewed by the interventionist. And also, this is where the hemodynamic nurse stays during the procedure to monitor the hemodynamic parameters of the patient during the procedure. And lastly, I would like to show to you the electrical room of the cath lab where the backup battery and the electrical components of the fluoroscopy machine are stored. Let me introduce to you the different sections of our catheterization laboratory in our hospital. First is the invasive cardiology section. Under the adult interventional cardiology, we often do a diagnostic procedure called coronary angiography. If we say coronary angiography, this is the procedure that uses X-ray imaging to see your heart blood vessels. The test is generally done to see if there is a restriction in blood flow going to the heart. Coronary angiograms are part of the general group of procedure known as heart catheterization. The goal of coronary angiography is to visualize the coronary arteries, branches, collaterals, and anomalies with enough detail to make a precise diagnosis of and plan of the treatment strategy for the coronary artery disease. So if there are significant lesions, we often proceed to percutaneous coronary intervention. As what you see in the screen, if your lesions are significant, more than 70%, we are going to do an intervention. If there are significant lesions, we proceed to percutaneous coronary intervention. But first, it is called coronary balloon angioplasty. This was first performed last 1977 until coronary artery bypass graft was the only alternative for coronary artery disease. And at present, it is now known as the percutaneous coronary intervention. So let's define the three terms. So if you say percutaneous, this is referring to the non-surgical insertion of a catheter into the body through a small puncture site in the skin, usually into an artery. And coronary, this is where we are going to identify what specific artery is affected. And intervention, if we say intervention, a technique for remodeling a blood vessel through the introduction of an expandable stent, balloon catheter, or other specialized tool for treating a diseased artery. In pediatric interventional cardiology, they always perform hemodynamic study, which they are going to measure the pressure of the different heart chambers. But for intervention, they commonly do device closure for congenital heart defect, such as your patent ductus arteriosus, in which a small vessel between the aorta and the pulmonary artery does not close at birth when neonates breathe right after delivery. Other procedures in which the wall of the heart, or commonly known as the septum, between the atrium and ventricles have a hole, which is your ventricular septal defect or your atrial septal defect. Another section in the catheterization laboratory is the interventional radiology. Actually, this is a medical specialty that takes an active role in performing a wide range of minimally invasive, image-guided procedures performed by certified and trained vascular and interventional radiologists. Some of the procedures can include cerebrovascular angiogram, aneurysm coiling, hepatic angiogram, and the like. They can also perform venous filter insertion. This is a type of filter that is implanted into patients who are at risk of complication like embolization of venous clots in the legs. The filter prevents a large blood clot from breaking loose and traveling to the lungs or heart, causing a stroke or pulmonary embolism. Another major section in the catheterization laboratory is endovascular surgery. This composed of surgical subspecialty who had a formal training in the diagnostic and management of diseases affecting all parts of the vascular system, excluding, of course, the coronaries and intracranial vasculature. The vascular surgery specialists are accredited by the respective society that are highly competent in performing open, complicated surgery, minimally invasive, and endovascular procedures. They often do venogram, peripheral angiography, in which this procedure allows the physician to evaluate the presence of plaque buildup. If there are, we will perform peripheral revascularization. This procedure allows the doctors to treat arterial diseases or your POD by using devices to improve the blood supplies to the extremities. And lastly, we have the electrophysiology studies section. We commonly encounter a patient here with cardiac rhythm abnormalities, and we usually do a procedure called permanent pacemaker insertion, implantation of internal cardioverter and defibrillator, radiofrequency ablation, cardiac resynchronization therapy, and others. With that being said, there are a lot of procedures that are technical and that requires expertise in a certain level. So who is a cardiac cath lab nurse in the catheterization laboratory? He or she is a registered nurse who specializes in assisting with catheterization. They monitor and examine patients prior to procedures, intra-procedurals, and post-procedures. They also administer medications and collaborate with the catheterization laboratory team in whatever they may need during the procedure. Cath lab nurses are a vital part of the cath lab care team. Their primary role is to assist the interventionist during the catheterization procedure. We do nursing assessment, we do nursing diagnosis, nursing planning, and of course, we have to implement our intervention and ensure and evaluate the interventions that we have implemented is effective. So what are some of the important responsibility of cardiac cath lab nurse that should be performed. Number one is we ensure that consent is being taken to our patient. Not only that, but we have to validate if they understand the procedure that will be performed then. You have to let them explain if what is the treatment that the doctor is going to do to them, and ensure that they have fully realized and fully understand the risks and complications. So if not, you can notify the doctor to explain again the procedure to the patient and ensure that their consent is being taken. Second is that we have to prepare the patient. One of our common problems before when we started doing cardiac catheterization procedures is that there are a lot of poor preparation of patients. That's why we ensure that we follow and we do follow-ups pre-procedure rounds to the patients who will undergo catheterization laboratory procedure. Number three, since most of our procedure are done in a local anesthesia, we have to monitor sedation levels during and after catheterization to ensure a patient is not experiencing an adverse reaction or an nephrotoxic reaction from dye. Kasi we usually use dye in a high volume amount, they don't have any adverse reaction towards the dye that is being used to them. So number four is we are going to assist in the interventional procedures such as balloon angioplasty, stent placement, rotablation, or cutting balloon, or any other interventional procedures that may take place inside the cath lab. So you need to be familiar with all the steps and also the procedure, the necessary materials that you are going to be needing during the procedure to prevent stress. Okay, so number five is we have to monitor patients for signs of infection or side effects following the catheterization procedure. One of the complications of undergoing cath lab procedure is your CRBSI, which is your catheter-related bloodstream infection, and we do not want that to induce to our patient. That's why we need to follow sterile technique during the procedure and after the procedure. And after the procedure, especially if they are outpatient, we have to process the discharge paperwork and ensure that we are going to deliver our health teachings after the procedure. Okay, and of course, do not forget to do your documentation. In our institution, we have already standardized qualification of nurses who is going to undergo our in-house cath lab training. He or she must have at least 2 years experience in a special care area, maybe in the coronary care unit, or in a surgical intensive care unit nurse, or an ER nurse, or pediatric intensive care unit nurse. And he or she should also be a BLS certified or basic life support certified and advanced cardiac life support certified. They should have undergone first a critical care training course, maybe taken in off-site training or in-house training in our institution. And lastly, in order for them to become a cath lab nurse, they should pass our catheterization laboratory training, which has a 3 months duration. So who is our catheterization laboratory team? So aside from the interventionists, there are another 4 roles that a nurse should assume inside the catheterization laboratory. So we have the hemodynamic nurse. So the hemodynamic nurse is responsible for monitoring the patient and the hemodynamic data. The monitoring nurse keeps the physician appraised of changes in cardiac pressures and rhythm. He or she will also be responsible in recording the used medical supplies by the patient during an interventional procedure. Second role of a nurse in the catheterization laboratory is the scrub nurse. He or she is needed for the assistance at the procedure at the table to provide the interventionist with all the equipment and supplies needed in order to carry out the procedure in the sterile field, of course. With our setup in the catheterization laboratory here in Ilocos Norte, we don't have clinical research fellow to assist them during the procedure. So it's only between the nurse and the interventionist. That's why we mitigate it by giving another nurse who is also highly trained in order for them to become their first assist. The third role of a nurse is being the cardiovascular nurse technologies. He or she is responsible in the preparation of the supplies that is needed for catheterization, such as your stents, guiding catheters, balloons, or etc. He or she will assist the doctors in the application of any intervention needed by the patient. Lastly is the circulating nurse. He or she is responsible in providing patient care before, during, and after the procedure. So what is the challenges that our nurses often encounter? So number one is presence of mind for cath lab personnel is very essential and fundamental during a procedure. You should always be ready for any complications that might happen inside the workroom. Second is keeping focus in the job that you are doing. This is commonly experienced by nurses who are recalled during on-calls, especially if they are already at their home and they have already set their mind in bed. Okay? So third is challenges like body aches, back pain, feet sore, and the like is very common inside the cath lab. We often had back pains, and not only lower back pain but also upper back pain because of the heavy protective equipment that we are using during procedure. Number four is on-call schedule. This is a universal concern of nurses all throughout the world, I think, in the cath lab. Unlike any other specialties, we need to condition ourselves that at any time we are being called in the middle of the night. So number five is radiation exposure. Radiation exposure is one of the scariest that will come into our mind or into your mind if you think cath lab. Although there are ways that being done inside the workroom, there are still probabilities to suffer from cataract or cancer. So make sure that radiation safety is being followed in the catheterization laboratory. And lastly, one of the challenges that we often need to face is the fast facing of the development of current trends in the field of the cath lab is really one of the challenges of a nurse. Although this will help us as a nurse in the lab to continue our personal and professional growth, we have to ensure that we keep up with the current trends or modalities of treatment as cath lab is concerned. In our institution, we have an initiative that was implemented in the catheterization laboratory. This best practice that was part of our breakthrough is to conduct a pre-procedural rounds and post-procedural rounds. We utilized a pre-procedure checklist in which we do 1 day prior to the procedure for admitted and elective patients. There are tasks that is listed in the form in which the nurse need to accomplish. Our significance as a member in the multidisciplinary team in the catheterization laboratory is important. A practice of a cath lab nurse may be new to the ear of some or known by many, but it is evident that this specialty continually upgrade and continue to empower nurses to explore the different type of nursing practice, which is also the aim of Scvnppi, that we really maintain and continue to upgrade the role of the cardiovascular nurses in the Philippines. I hope that I imparted the significance of the role of nurse in the cath lab or inspire someone to also pursue this specialization. Thank you and God bless everyone.
Thank you, Mr. Richard Irvin Busmonte, for that very interesting topic. Sheena, ikaw ba gusto mo maging cath lab nurse?
I don't think that's for me.
Di ba? Parang medyo mahirap
It's
na.
hard, yes.
Maraming require na
Yes.
education, more training, ganyan. So before we continue, let us batiin mo natin yung mga sponsors. Let's thank them. First is yung ating Bron. Thank you, Bron. IBS Medical Systems Philippines Incorporated. Thank you po.
Philcare Pharma, Technomed, and Lifelink.
And also thank you, Boston Scientific. Terumo Cardiovascular.
Medical Tech Incorporated,
Lister Corporation,
SVT Meditech Corporation.
and East Lane Corporation.
Thank you to our generous sponsors.
Before tayo mag-continue, meron pong ipa-play ang Bibron na video presentation. Let us watch this.
Our lives are defined by our values. But what is the most valuable thing we have? At B. Brown, we believe it's human life. And that's why around 50,000 experts from B. Brown work every day in 60 countries on every continent to protect people's lives. Good health is life's most effective safeguard. To improve or maintain health is our goal for 175 years. With every product that leaves our company, we deliver the promise to share our knowledge in the field of healthcare in a constant dialogue with our customers and partners. This mutual effort results in uncompromising quality in order to preserve and improve the health of patients. B. Brown, sharing expertise.
first session of our morning
Yes, I
session.
think Sheena, ituloy-tuloy na daw natin.
Okay.
Yes. But before we continue with our second topic, we would like to acknowledge first Ma'am Crisel Galang, who is our Deputy Executive Director for Nursing dito po sa Philippine Heart Center. Ma'am, welcome po. Good morning.
Thank you for joining us, ma'am.
And now let us move on to our next topic. Our speaker is a graduate of BS Medical Technology from FEU NRMF last 1994. In 1998, she finished her degree in Doctor of Medicine also from the same institution. At present, she is a Medical Specialist 3 at the Philippine Children's Medical Center. She specializes in pediatric cardiology with subspecialty on pediatric echocardiography. To give us a lecture on spreading good news or grown-up congenital heart news, the transition of CHD from pediatric to adulthood, let us welcome Dr. Rachel Angeli R. Ninyalga.
Good day, everyone. Before anything else, congratulations and warmest greetings to the Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated on your 21st annual convention. I am Dr. Rachel Angeli Ninyalga, a pediatric cardiologist and echocardiographer, and let me thank the organizing committee for inviting me to give you an overview on grown-up congenital heart or GUCH, and now more universally accepted as adult congenital heart disease or ACHD. I have nothing to disclose. While congenital heart disease is the most common birth defect with a global birth prevalence of 8.2 per 1,000 newborns, the prevalence in the grown-up population is not known, and the absence of exact numbers has made planning difficult. But because of tremendous advances in diagnostic and surgical techniques, survival of patients with congenital heart disease has improved such that there are now more living adults with congenital heart disease than children in developed countries. Adolescents and emerging adults of transition age are estimated to comprise 15 to 20% of the overall population with congenital heart disease. In high-income countries, 90% of afflicted children can reach adulthood. Although congenital heart disease survival continues to be rare in low-income countries, increasing access to pediatric cardiac surgery in middle-income countries has resulted in a small but growing number of teens and adults living with moderate and complex congenital heart disease. Consequently, patients and families need to be prepared for the emerging adulthood. Congenital heart disease is a lifelong condition. Irrespective of initial treatment in childhood, patients are at risk for complications such as heart failure or arrhythmias. To support patients throughout their entire healthcare life trajectory, lifelong specialized cardiac care is required. For most patients with congenital heart disease, follow-up in an expert center for adult congenital heart disease is advised. The transfer of care usually takes place when patients are transitioning into adulthood. However, this is not necessarily the case for all centers. Studies indicated that the transfer to adult care in congenital heart disease is often associated with interruption in cardiac follow-up and that patients are insufficiently supported during their transition to adulthood. Most middle-income countries are still developing pediatric cardiac care systems, and adolescent congenital or adult congenital heart disease programs and or clinicians are rarely available. However, the association between adult congenital heart disease care maintenance and better outcomes is well established, and all settings should aspire to an organized and coordinated process that prepares congenital heart patients to independently manage their lifelong care needs. Disparities in the medical care of the growing congenital heart disease adolescent population exist, including poor transition from child-centered to adult-centered healthcare, lack of appropriate transfer of care, and this is concerning as many patients drop out of active health care during this time, and lapses in care appear to be predictors for morbidity and poor outcomes, particularly for minority populations. Simply put, transition is an age and developmentally dependent process that addresses the medical, psychosocial, and educational and/or vocational aspects of moving care from child-centered to adult-centered health system. While transfer refers to the point at which adult care provider assumes the medical care of a patient. And transitional care involves the interventions necessary to provide holistic care to the adolescent as they move up to adult care. There are different rationales for setting the age of transition and age of transfer based on the recommendations from the American College of Cardiology, European Society of Cardiology, and British Cardiac Society. Being pediatricians with strong background on the stages of adolescent development and in consideration of our cultural values, we set the transition age at 16 years and transfer age at 19 years for the GUCH and transition program at the Philippine Heart Center. The make of a specialist clinic for congenital cardiac disease will be significantly different for children compared to the grown-ups. Simple lesions will have been treated definitively or require no further assessment. The clinic for grown-ups will have a disproportionate representation of lesions at the severe end of the spectrum. Some patients reach adulthood without having had or needed surgery. Natural survivors include patients with relatively minor abnormalities, as well as those with complex conditions and balanced physiology. They also include patients with established pulmonary vascular disease. Some patients will also present for the first time as adults. Majority of patients in a specialized service will have had one or more palliative or corrective operations in childhood, and these operations include the inevitable need for replacement of biological and prosthetic valves or conduits, as well as procedures designed to deal with residual hemodynamic lesions, such as pulmonary regurgitation after repair of tetralogy of Fallot. Survivors of definitive surgery for complex defects often have notably abnormal circulations. Late electrophysiological and hemodynamic problems after procedures such as the Fontan operation or the intraatrial repair of transposition, including mustard or Senning operations, have become apparent and are progressive. Severe heart failure is likely to occur in an increasing number of patients, with requirements for both specialized medical care and surgical intervention. So how do we set up the GUCH and transition clinic? We have requirements to fulfill. These include patient stratification, transition of care, including the policy, institutional requirements, staff requirements, equipment requirements, other additional requirements, collaboration and infrastructural requirements, and training requirements. I have listed down the staff requirements based on the American College of Cardiology, European Society of Cardiology, and British Cardiac Society, and the requirements that the Philippine Heart Center has fulfilled. These include the presence of the pediatric cardiologist, adult cardiologist, imaging specialist, congenital invasive or interventional cardiologist, electrophysiologist, of course, our congenital surgeon, congenital heart surgeon, the CV anesthesia, very important, the nurse practitioner, psychologist, social worker, and even cardiovascular pathologist. Currently, we only have one board-certified and trained adult congenital heart disease who happens to be an adult cardiologist. So this is an area where we need to train our future cardiologists. Other staff requirements include a dental specialist, specialist links like in genetics, endocrinology, pulmonology, neurology, and non-cardiac surgery. The presence of obstetrician, liaison officer to GUCH associations, a medical secretary, research coordinator, and of course, a training program. So some of them, the Philippine Heart Center has not yet fulfilled. The following concepts are reviewed in the pre-transition education. The need for ongoing specialized adult congenital heart disease care throughout adulthood, importance of patient's assumption of healthcare responsibility, parental and/or family support of patient healthcare assumption, importance of communicating concerns, symptoms, and etc. to the cardiologist, medication compliance, administration of endocarditis prophylaxis as needed, general information about reproductive health and pregnancy planning, insurance issues, both medical and life insurance, even societal support and benefits, of course, vocational counseling, and the promotion of healthy lifestyle, advices on alcohol consumption, tobacco use, against illicit drug use, weight control, exercise, sports, and hobbies, and avoidance of stimulants. The patient stratification of the American College of Cardiology is based on the complexity of congenital heart disease. For the European Society of Cardiology, it is based on level of care, while for the British Cardiac Society, it is based on special risks and complications. Factors influencing successful transition include the following: close proximity to the Adult Congenital Heart Disease Center, history of multiple cardiac surgeries, a positive attitude of the pediatric provider toward transition, therefore impacting the patient's attitude toward transition, older age at the time of last cardiac visit, those utilizing antibiotic prophylaxis when indicated, and those independently attending appointments. The lack of patients continuing in specialized adult congenital heart disease care stems from multiple factors. Many were simply lost to follow-up. There's a perceived lack of cardiac symptoms, so they don't follow up. Ignorance regarding the need for long-term surveillance. They feel they don't need to. Lack of access due to travel and insurance barriers. Many cardiac centers have inefficient or no existing patient tracking systems. And the misconception that cardiac disease has been cured by surgery. According to the American Academy of Pediatrics, there are 6 core elements for a successful transition and transfer program. These include transition policy, tracking and monitoring, readiness assessment, transition planning, transfer of care, and transfer completion. The following are some special concerns for the adult congenital heart disease patients or GUCH patients. Preventing infective endocarditis, the development of arrhythmia and the need for electrophysiological studies, the development of other acquired heart diseases, the development of pulmonary hypertension secondary to the congenital heart disease, procedures such as cardiac catheterization and intervention, of course, dental care, issues on contraception and pregnancy, which should be discussed with the perinatologist, sports participation, of course, employment and insurance, and availability of palliative care, including advanced directives. In conclusion, there is no universal consensus regarding how transitional care should be provided and how the transfer should be organized. Transitional care and the transfer to adult care settings are important for all adolescents with congenital heart disease. Available resources will determine which components of transition programs can be implemented and who will be able to perform this? Regardless, symptoms must be in place to ensure that continuity of care is ensured after leaving pediatric cardiology. And I cannot overemphasize the need for a teamwork approach, especially with the help of our nurse practitioners who are ideally to become the transition coordinator or nurse manager. Here are my references. Thank you for listening.
Thank you, Dr. Nyaga, for that comprehensive topic on Bush and CHD. I think this lecture is really timely because we have been seeing a lot of grown-up congenital heart disease in practice, and these transition and transfer programs will be beneficial for the continuity of care of our patients. Again, thank you, Dr. Nyaga. At this point, we would like to open the floor for your questions and reactions regarding the topics discussed. Send in your questions by clicking the Q&A tab, click the Ask a Question button, and type in your question and click Send. Your moderators will read the questions, and our resource speakers are here and ready to answer.
Yes, and also may we call in Sir Bismonte and Dr. Ninyalga para ma-ready na po tayo sa ating mga questions because the questions are coming in right now.
Good morning, Dr. Ninyalga and Sir Richard.
Hello, good morning, everyone.
Good morning.
So meron tayong first question dito. First muna kay Sir Richard. Hello,
Yes,
sir.
sir.
Good morning. What are the specific challenges of cath lab nurses in dealing for patients who are COVID positive?
Hi, good morning, everyone. And first of all, I would like to congratulate the Society of Cardiovascular Nurse Practitioners for this successful annual convention. First is all about the experiences of our nurses in the cath lab. First is, of course, the difficulties and challenges on putting up an added protective measures for us not to be infected with COVID positive. So on top of our lead gown, we are also using the coverall. Although the temperature inside the catheterization laboratory is very cold, but it is blocked by the cover. Also, it's very hot, so we are wet with our sweat, and it's really difficult for us because after that we have to really take a bath so that we can ensure that we will properly disinfect also our body. And second is on-call preparation, of course, for COVID positive patients or suspect and even probable, because we have to treat the patient as COVID positive even though they are suspect or probable. So the preparation should be done for 30 minutes to 1 hour. So aside from being on call in the middle of the night or during weekends, because we only have one room for cath lab, we have to make it the pacing very fast so that we can attend to, especially if that is an emergency coronary intervention and percutaneous coronary intervention. That's all. Thank you.
Ang hassle, no? Nang merong hazmat pa, tas ang init.
Yes.
But
Guys, malamig.
Efficient, effective ka pa din sa loob ng cath lab.
Yes, there are a lot of challenges ngayong COVID.
Next question po kay Dr. Ninyaga.
What are your great challenges in starting GUSH in your institution, Doctor?
Oh, it's a great challenge for us to be able to put a GUSH and transition program in Philippine Heart Center. Fortunately, we have a very supportive administration who recognizes the need for the continuity of care of these patients with congenital heart disease who will have to transition into the adulthood. Remember that during the maybe 1980s, 1990s, there were not much congenital heart surgeons, no, and not much congenital heart disease surgeries. But in the decades that followed, we saw the rise of early recognition of congenital heart disease by the pediatricians and by the pediatric cardiologists. And somehow it paralleled the progress and the development of congenital heart surgery. So now we have more congenital heart surgeons operating on both pediatric and adult patients with congenital heart disease. So we now see more survivors of congenital heart disease. And right now, we are advocating early surgery. So mostly newborns and in the first year of life, we try to correct as much as possible the congenital heart disease. And they grow into the adult, and they grow into young children, young adults, and adolescents, and later on adulthood. So we will now see more survivors of congenital heart disease. So I think any hospital or any cardiac center must recognize that they have to take care of these patients. Hindi naman ibig sabihin kasi na na-correct yung congenital heart disease or even total correction, no? Excuse na sila at well off na sila into the adulthood. Monitoring is always the key because sometimes yung mga cardiac surgeries nila will have to be reoperated on if they have residual defects that were observed in the years that followed, or they have outgrown the shunts, correct yung isang nagtanong, no, they have outgrown the smaller valves that were placed when they were children, so they need to be monitored into the adulthood. And fortunately we have congenital heart surgeons, no, who take care of them. So, and dumadami na sila because of the emerging programs in congenital heart disease surgery. And we are hoping that some of the adult cardiologists will pick up the interest of taking care of these patients because nagsusurvive na sila eh. So I think this is a challenge for the adult cardiologists to start taking care of patients with congenital heart disease who have grown into the adulthood.
Follow-up kay Dr. Ninyarga. Doc, you mentioned tracking and monitoring sa mga GUCH patients natin. Paano niyo po na-implement yung tracking and monitoring natin?
Actually, this is very difficult for us because what we are doing right now, no, 5 years into the program of the GUCH and Transition Clinic of Heart Center, is just registry. We have not really followed up most of these patients. The follow-ups are basically separate pa rin with the pediatric cardiology if they are still within less than 19 years old, and with the adult cardiology by 19 years of age. So this is an area where we should improve, no? So I think this is where yung permanency ng staff of a GUCH and Transition Clinic is very welcome, and sana mapunuan natin itong gap na to. And I think if you read on literature on the success of GUCH and Transition clinics abroad, it is actually the transition coordinator who is the best person to take care or manage this clinic. And who are these? They are mostly nurse practitioners. So kasi may permanency kapag kapag merong GUCH and Transition clinic manned by a trainee transition coordinator, because the doctors come and go, and they can only advise, they can only facilitate the procedures, but the follow-ups, yung monitoring tracking system is best done by the transition coordinator.
Okay, so na-recognize talaga yung role ng nurses, no, as para mag-track ng mga GUCH patients natin. And sir, may isa pa kaming question for you, Sir Richard, no? How do you deal, sir, with your extra time that your nurses are rendering during on-calls?
Actually, that is really one of a challenge because we are just one team. We are actually composed of 4 nurses every on-call because of the responsibilities of the cath lab nurse inside the workroom. We ensure that we really standard our process in terms of giving the extra time of our cath lab nurse. our cath lab nurse actually have the privilege to really have their time back if we have a few procedure or if we finish earlier, because sometimes there are experience of our staff nurses that they will come in the middle of the night and we have to attend again a procedure at 8 o'clock in the morning. That's why if we're going to um, require them to come earlier for that procedure, we have to ensure that we are going to give also their request, especially if there are some important dates that they are going to attend to. We are going to consider them that on top of their privilege leave, they can also have their time back. So para ma-compensate din namin yung mga sacrifices and even their time that they were extra giving to our institution.
Okay, thank you, sir.
Thank you, sir. Last na lang po. Mr. Bismonte, can cardiac or cerebral catheterizations be done as an outpatient?
Okay. So, di ba, there are two separate entities kasi with that. So, we have two sections for that. For invasive cardiology, especially for adult, we can do outpatient basis for coronary angiography, especially if we just do transradial approach, except for femoral approach, kasi they have to lie flat on bed for 6 hours so that they have to stay on our short stay unit and spend there overnight. Okay? But for cerebral angiography, we require them, actually our doctors, our interventional radiologists require them to be admitted because they are still used to with their femoral approach. They are still not doing transradial approach for cerebral angiography.
Thank you, sir. Let's see if we still have additional questions. What is your STEMI team, sir? Is it a 3-man or a 4-man team?
Actually, in all, we are a 6-man team. Together with our interventionists and our interventional radiologic technologists and another 4 nurses. So those were the team that composed our cath lab team during on-call. So lahat yon pumupunta sa cath lab namin. Good for us in Ilocos Norte, hindi ganun ka-traffic. That's why madali kami nagre-respond. So within 30 minutes, kahit nasa mga 17 kilometers away from the hospital, they can respond with our on-call.
Thank you, sir, and for Dr. Ranil Nyalga. Are there enough pediatric cardiothoracic nurses that can take care of the patients post-op, or the adult cardiac ICU nurses take care of them as well in the immediate post-op?
Of course, I am in a bubble where we have the complement of all cardiovascular manpower at the Philippine Heart Center, no? So kung sa Philippine Heart Center ang pag-usapan natin, yes, we have enough. And the adult SICU nurses might be able to take care of the adolescents, no? Not really the infants, no? Anyway, the standard of care is similar for both pediatrics and adults in the post-operative setting. So, yung parang familiarity lang ng mga nurses in taking care of kids. Kasi mas mareklamo sila sa pain, no? Mas malikot sila. They need to be entertained, no? They need to be talked to. So, iba yung level of care. Parang ikaw yung second parent nila na nandoon sa post-op ICU.
Thank you, Dr. Ninalga. And to add to that, in Philippine Heart Center, post-op, because I'm a surgical ICU nurse, in adult setting, if the patient is intubated or fresh from OR, the patient-to-nurse ratio is 1:1. I think it is the same in pediatric post-op care.
Yes, 1:1 always.
for Sir Richard, sir, my question dito, what is your time range to open a blocked artery meeting all the criteria?
Actually,
Katagal yung procedure, sir?
okay. In our institution, we consider from door to balloon time, we always consider the 90 minutes window period. So on top of that, sabi ko nga, we at least 30 minutes we are already on the cath lab so that we can prepare everything. Kaya nga during pandemic, it's very hard for us to meet that time. But with our record, we can say that we still we achieve that door to balloon time na 90 minutes. So we can easily respond during emergencies.
Okay, thank you, sir. Thank you po.
Thank you.
As much as we'd like to answer all the questions, I think we'll end it here. And I think our panelists can type in their answers in the chat box. Thank you, Dr. Nunyaga and Mr.
Thank you, Sir Richard.
Richard
Thank you po.
Busmonte.
Thank you.
to our
Congratulations.
participants.
Thank you.
Thank you for that engaging discussion. Thank you to our participants.
And now we would like to present the certificate of appreciation to our resource speakers. The Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated would like to award the certificate of appreciation to Mr. Richard Irving M. Bismonte, RN, MAN, in grateful recognition of his invaluable contribution as resource speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th day of May in the year of our Lord 2022. Signed, Jesus Ferdinand B. Peralta, RN, the chairperson of the Scvnppi 21st Annual Convention, and Janine L. Comendador, RN, DDM, the president of the Scvnppi.
Also, the Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated would like to award the Certificate of Appreciation to Dr. Rachel Angeli R. Viñalga in grateful recognition of her invaluable contribution as resource speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th day of May in the year of our Lord 2022. Signed, Jesus Ferdinand B. Peralta, RN, chairperson of the Scvnppi 21st Annual Convention, and Janine Comendador, RN, DDM, president of Scvnppi. Again, thank you to our participants and to our speakers.
Thank you po.
We will now be having a virtual game named Kahoot. And yes,
Kahoot game.
a Kahoot game.
Kahoot game.
Yes, and I'd like to, it is a virtual game, and in order to claim your prizes, you should have a valid and working GCash account. The mechanics of this game is, can you please kindly go to the link being flashed on your screens and key in your PRC numbers as your name? Then you will be given 5 questions. You have to answer the questions correctly and as quickly as possible.
Pabilisan.
Yes, patamaan, pabilisan. Only the top 3 shall be awarded the prize as follows.
Magkano?
Malaki to.
Okay, naku, nakakabuhay ng pamilya.
Yes.
Yan. Ang top 1, o yung pinakamabilis natin na may tamang sagot ay makakuha ng 500 pesos.
Top 2 will receive 300 pesos.
And yung ating third ay makaka-receive naman ng 100 pesos.
Pwedeng pambili ng iPhone 13.
Pwede. May load na din yun.
Yes. So, in order to start, kindly join lang po. We're waiting for you guys to join.
We are waiting for our players.
Yes.
So may link naman na sinend, no? Di ba, Sheena?
Yes, yes.
Dun sa ating
You
game.
can use the QR code so you
Yes.
can get inside the link. Oh, we have one contender. Oh,
Ayun,
yeah,
may top 3 na tayo.
may
Ayun,
panalo na ba?
Again, we'd like to remind everyone to please key in your PRC license numbers as your mga names nila. Oo. Kasi baka parehas na Mark, parehas na Mark
Yes.
Ryan, parehas na Jessica Marie, parehas na
Juan de la Cruz.
Juan de la Cruz. Medyo mahirap yan.
PRC numbers, guys. Can you key in your PRC numbers? Very good. Kindly key in your PRC numbers as
PRC
your
numbers,
name, as your
yes.
usernames.
Okay. Pag-plug po ang inyong PRC, again, PRC license numbers without the name.
Yes, can you,
Yung PRC license numbers lang.
if you cannot rename it, baka pwede ka mag-log out and log in na lang
Yeah.
again as your PRC ID numbers.
Mhm.
Baka hinahanap pa kasi yung PRC
Oo,
ID numbers.
Baka nasa Trodat.
Yes.
Nasa Trodat.
Hanapin na ang mga Trodat or start nang i-memorize ang PRC numbers.
Kasi mag-disregard po yung ating player na hindi yung PRC license number yung naka-enter, yung naka-log. Okay?
If you cannot rename it, log out muna kayo sa Kahoot, then log in na lang ulit as your PRC ID number.
Yan, marami-rami na tayong players. May 52 players na tayo.
We need more contenders. Ang laki ng prize. Oo, pang Starbucks na rin to. Oo, hindi ka na makakapulot niyan. 61! We now have 61. Yung mga names pa rin po, sayang. Please log out muna, then log in na lang or rename kung may option na gano'n.
Ano kayo mga questions? Multiple choice ba to? Or select all that apply, mga ganun?
Ano pang NCLEX? Preparation na pala to for NCLEX. Sa mga hindi pa nagkaka-NCLEX. Very nice. 66 contenders. May mahahabol pa ba so we can start?
Yep.
Yung mga names po, ma-disregard po kayo. So please log in as your PRC ID number.
Yes, log in with your PRC license numbers. While waiting for our players, we would like to thank again our sponsors.
Yeah.
Brown, thank you so much. Ideas Medical Systems Philippines Incorporated, thank you.
Boston Scientific and PhilCare Pharma, thank you.
Technomed and LifeLink.
Torino Cardiovascular Medical Tech Incorporated.
Lister Corporation and SVT Meditech Corporation.
And last but not the least, East Lane Corporation.
Thank you po, thank you.
Ayan, 81, 83. May hahabol pa ba? Last 30 seconds. Pressure. Hinahanap pa daw nila. Wait lang.
Oo, nasa akin yung ID na
Wait
sa
lang.
mga license natin na yan.
Pwede niyong gamitin yung license number ko. Char. Para makasali ako.
Or yung passport, hindi, joke lang, but our passport, PRC license po tayo.
Okay. 84 contenders. May habol ba sa mga nag-log out? Then magla-log in ulit. Last 20 seconds. 84.
Again, reminder, ang ating pong pang-log is yung ating PRC license numbers. We're still seeing po na participants na name yung nakalog.
Yes, bigyan pa namin kayo ng
Oo,
chance.
sayang, malay nyo si Ange pala yung mananalo or si Lalaine pala yung mananalo. Kaso disregard kasi yung name niya yung nakalagay at hindi yung PRC
Yes.
license number niya.
Last 10 seconds. May chance pa kayong palitan ang inyong mga names into your PRC license number. Okay, we'll start na in 10 seconds. Okay. I think that's it. Close na po.
Okay.
Let us begin our Kahoot game.
Ano kaya yung mga questions na po?
100 contenders for top 3.
Ayan.
Mahigpit
Sige,
ang
sige.
laban.
Maganda to, maganda to.
Okay, ready?
Hindi ako nakapag-log.
Wala bang gumamit ng license number ko?
Question number 1. Who is the founder of the Scvnppi? Na-mention namin to kanina.
Pabilisan po to ha. Tama dapat na mabilis.
Sino kaya ang naka 2 seconds lang or 0.5 seconds?
Si Miss Felicissima Romero ba? Miss Janine Comendador?
Founder po hindi po yung president, hindi po yung former president, yung founder po ang hinahanap natin.
77 answers are in. The correct answer is
Answer the blue. Who is?
Miss Maria Linda Buhat.
Which is the correct answer.
Congratulations sa
po.
nakakuha ng tamang sagot. Next question. Pabilisan to guys ha, tapos dapat tama din. Oh, nangunguna si 0826277.
Bagong graduate, no? Bilis talagang bilis na.
Bata pa.
Mabilis.
Mabilis pa. Tayong mga tita, mabagal na. Okay, next question. May chance pa pong humabol. Don't lose hope.
Yes. Question number 2. Who is the current treasurer today in the Scvnppi? Alam ko yung sagot kasi nasa script natin yan.
Dapat kasali tayo.
Kasali talaga tayo.
Si Mr. Jesus Ferdinand Peralta ba? Miss Joyet Mindoro? Miss Felicissima Romero?
So parang pwede dito yung process of elimination. Okay, tapos na.
Oh, 45 answered. Miss Joyet Mindoro. Which is the correct answer.
Correct answer, yes.
Yes, gagaling. Ang bibilis ng kamay.
Sino kaya na this
Sino
time?
na? Miss the leading contender. Oh! Nagbago.
Bago.
Feeling lang naman natin. Remember kasi. Sa ano? Si ano na? PRC license number 0371516.
Okay, this question lang.
Parang scoreboard talaga
lahat
siya.
na.
Nagbabago siya. Kaya galing
So
na.
don't worry, second question pa lang naman ito. Meron pa tayong 152 questions.
10 clicks pa lang.
Pwede pa lang.
Okay, next question.
Third question.
So may chance talaga.
What does Scvnppi mean?
Ang haba.
Ilang beses na rin naman nating nabanggit to, di ba?
Oo, tsaka nasa logo naman ng mga slides. 58 answers ang bibilis. 70 answers na.
2, 1, 0. Time is up.
Very
The correct
good.
answer is letter A, Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated.
Congratulations! Sino na ang top 1? Na-maintain ba ang kanyang spot?
Maintain ba ang-
Oh, hindi. Oh, si top 2 na ang top 1 ngayon.
Mabilis.
Congratulations! Kasi naman, PRC license number 0396272. Ang
Congratulations.
bilis ng kamay.
Nakasak na yung 500.
Oo, nararamdaman na.
Nararamdaman ko makating yung palad.
Oo, malapit na. Next, magpanghinaan ng loob, kailangan lang mabilis ang
Question
kamay.
number 4. Who is the current president of the Scvnppi? Meron pa. 10, 9, 8, 7,
74 answers are in.
4, 3, 2,
1.
The correct answer is
Miss Janine Comendador. 53 got it right. So, wow! Na-maintain ang first spot!
parang kilala ko yun.
Feeling ko din. May lukso na ako ng dugo kung sino. License number 0396272.
Oh, mabilis.
Okay, last question. May chance pang humabol kasi
Last question na.
yes, kasi 30 lang yung lamang niya. May chance pa si top 2 humabol. Next. Last question.
Last question. When was Scvnppi established?
Ito ata pinakamahirap pa.
Mahirap. So 21st convention to, so minus 21. So mali ako.
Naisip ko din yun.
So the answer is April 10, 2000.
Oh,
Medyo malapit na rin, di ba?
Oo. Tama. So, who won? Oh, top 3 with PRC license number 0396272.
Ang second place natin ay si 0767788.
And our first place is 0297656.
Congratulations, winners.
Congratulations. And in order to claim your
Paano
prizes,
ma-claim yung prize?
kindly Viber this number. Oh my gosh, isusulat niyo. We will type it in the chat box.
Sa
Don't
chat
worry.
box kung paano natin i-claim yung ating
Yes.
prize.
Viber nyo yung number 0977-2354-837, your full name, and send your PRC picture, the picture of your PRC ID.
Yung license na yung kailangan natin, hindi na yung throwback.
Baka selfie mo isend ha, your PRC ID picture. Kaya kindly send it. And message kayo, send GCash please. So, congratulations to all the winners. After this, we will be having a video presentation from B.
Again,
Brown.
from the B. Brown.
Yes, one of our major sponsors.
Let us all watch this.
to protect people's lives. Good health is life's most effective safeguard. To improve or maintain health is our goal for 175 years. With every product that leaves our company, we deliver the promise to share our knowledge in the field of healthcare in a constant dialogue with our customers and partners. This mutual effort results in uncompromising quality in order to preserve and improve the health of patients. B. Brown, sharing expertise.
So ngayon alam mo na, ano na, tara naging kabady ka na. Di ka na pwedeng umurong pag umuo ka. Pero pangako kong mamahalin kita.
Baby, what's your name? Iba ka kanina ko pag gustong tanungin.
Don't wanna play no game.
No, 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 no.
Play around me, baby.
Di na uso sa'kin makipaglaro.
Baby, come around me, baby. Lahat na makakaya ko ibibigay sa'yo. Play around me, baby.
Gusto ko palagi na dyan.
Baby, come around me, baby.
Jenny Bower.
Come on now, baby.
Baby, baby, what you doing tonight? I see that look in your eyes. I feel the same. Yeah. It's your lips, girl, when we kiss. Why don't we handle this? Girl, you know I need some affection.
But I guess I really don't care. I probably should wait, but I wanna let you go there. I wanna try something new. Oh, no.
Yo, hey girl, yo, bring it back to the time when you and me had just begun. When I was still your number one. Well, it might seem far-fetched, baby girl, but it can't be done. I got this feeling, fire blazing, and it hot just like the sun. Know you feel it too, my girl, just breathe up, man, the good vibes run. Girl, take a sip of the champagne, take a little trip down my lane, my girl. Wilding out every night, I will feel alright. Make I tell you this, girl, that's my world. Not change, I'm not rearrange, hey girl, I'ma tell you this shit, that's my word. I'm here, say you want come kiss this girl, cause you missed it. That's what I heard. That's what I heard. That's what I heard. Well,
Tonight, there's nothing left to say. Don't waste enough. Don't waste enough. If it's alright with you, then it's alright with me. Baby, let's take this time. Let's make memories.
Like a leg in the sky.
Yo, King Kong, yeah, yeah, yeah. We so wow, 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 wow. Yo, King Kong, yeah, yeah, yeah. We so wow, 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 wow.
Can you hear me roaring? 난 이 발을 드러내지 네 먹기가 되는 대신 Don't you know that I'm a savage?
You don't wanna start movies dangerous. 내게 저 피부 아는 대신 선은 넘을지 몰라. True, this is awesome, wow. Just like a zoo. Follow your true. Party, yeah, play, yeah. You know what to do. Just like a zoo. Follow your true. Party, yeah, play, yeah. You know what to do. Yeah, yeah.
So ngayon alam mo na, ano na, tara naging kabady ka na. Di ka na pwedeng umurong pag umuo ka. Pero pangako kong mamahalin kita.
Baby, what's your name? Iba ka kanina ko pag gustong tanungin.
Don't wanna play no game.
No, 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 no.
Play around me, baby.
Di na uso sa'kin makipaglaro.
Baby, come around me, baby. Lahat na makakaya ko ibibigay sa'yo. Play around me, baby.
Gusto ko palagi na dyan.
Baby, come around me, baby.
Jenny Bower.
Come on now, baby.
Baby, baby, what you doing tonight? I see that look in your eyes. I feel the same. Yeah. Taste your lips, girl, when we kiss. Why don't we handle this? Girl, you know I need some affection.
But I guess I really don't care. I probably should wait, but I wanna let you go there. I wanna try something new. Oh, no.
Yo, hey girl, yo, bring it back to the time when you and me had just begun. When I was still your number one. Well, it might seem perfect, baby girl, but it can't be done. I got this feeling, fire blazing, and it hot just like the sun. Know you feel it too, my girl, just freeze up, man, the good vibes run. Girl, take a sip of the champagne, take a little trip down my lane, my girl. Wildin' out every night, I will feel alright. Make I tell you this, girl, that's my world. Not change, I'm not rearrange, hey girl, I'ma tell you this straight, that's my word. I'm here, say you want come kiss this girl, cause you missed it. That's what I heard. That's what I heard. That's what I heard. Word, girl.
There's nothing left to say, don't waste enough, don't wait. If it's alright with you, then it's alright with me. Baby, take this time, let's make memories.
Like a leg in the sky. Yo, King Kong, yeah, yeah, yeah. We so wow, 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 wow. Yo, King Kong, yeah, yeah, yeah. We so wow, 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 wow.
Can you hear me roaring? 난 이 발을 드러내지 네 먹기가 되는 대신 Don't you know that I'm a savage?
You don't wanna start movies dangerous. 느껴져 피부 아는 대신 손에 넘을지 몰라. True, this is awesome. Wow,
Just like a zoo. One of your true. Party, yeah, yeah. You know what to do. Just like a zoo. One of your true. Party, yeah, yeah. You know what to do. Yeah, yeah.
the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. I have been to sorrow, I have been to bliss. Where I'll be tomorrow, I can only guess. Through the darkest desert, through the deepest snow, forward, always forward I go. What a journey it has been. In the end is not in sight, but the stars are out tonight. shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. Forward, always forward. Onward, always up. Catching every drop of hope in my empty cup. What a journey it has been. And the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. What a journey it has been, and the end is not in sight, but the stars are out tonight, and they're bound to guide my way. When they're shining on my life, I can see a better day. I won't let the darkness in. What a journey it has been. What a journey it has been.
Years na palang SCvnPPI, no? So, paano ba tayo mag-member dito? We're encouraging everyone to be a member of the Society of Cardiovascular Nurses Practitioners of the Philippines Incorporated. You can visit the scvnppi.org at doon po natin malalaman kung paano tayo mag-member. So, ang alam ko, it's parang 400
400
ang membership fee. Tapos, it's valid for 1 year.
Yes. So what are you waiting for?
So, nanalo ng kahot kanina.
Pa-member na ba?
Yung dalawa ng SCvnPPI natin. Another important reminder is yung ating sa Q&A.
Yes. Kindly type in the chat box na lang po all your questions so that we'll be able to address it. If not live, our speakers are there ready to type in their answers. So thank you again for the overwhelming support. We have more than 600 participants. And our heart is very full. Thank you for joining us today po.
At ano pa ba yung mga aabangan natin ngayong convention? Ano pa yung mga programs natin? Natapos na tayo sa ating dalawang speakers. Ano pa yung susunod nating?
We have more speakers. We have two more
speakers. Yes.
And our program is divided into two. We have the morning session and the afternoon session. So I hope you guys will join us hanggang hapon po because your evaluation forms will be flashed at the end of the program.
Yes, and bukod sa ating mga resource speakers or sa ating mga keynote speakers, meron din tayong presenters ng research later.
Yes, Philippine Heart Center research team. Yes, we have research presentations because we believe in evidence-based practice.
Practices, yeah.
Yes.
And also, meron din tayong isa pang Kahoot game later. Ang alam ko, no?
Oo, nag-enjoy ba kayo? I hope you enjoyed our Kahoot game. No?
Another 5
more
questions. 5 questions na pa.
5 lang.
Kala ko 5,000 pa.
5 more
5 more
questions.
Okay.
And then, same, kukuha po ulit tayo ng top 3 winners.
Yung mabilis at yung may tamang sagot.
Yes. So, pabilisan to. So, nakita nyo naman, warm up lang yung kanina. May chance pa kayong sumagot later. Pabilisan ng kamay at ng connection. Apparently, may nalolog out daw kasi. Yes, and again, we'd like to thank our sponsors.
Yes, thank you so much, B. Brown, Ideas Medical Systems Philippines Incorporated,
Boston Scientific, Philcare Pharma.
Also, thank you Technomed and LifeLink.
Special thanks to Terumo Cardiovascular and Medical Tech Incorporated,
Lister Corporation, SVT Meditech Corporation,
and last but not the least, East Lane Corporation. Thank you to our sponsors.
Thank you so much, sponsors. And again, i-remind lang natin yung ating mga Q&A later. Magsasalita po muna yung ating mga speakers. Yung ating 2 speakers, magsasalita muna sila.
Before we address our questions.
Pero you can type in your questions, diba, para babasahin na lang natin later.
Yes, anytime yes. During the lecture. But we have a specific time slot wherein we will address your Q&A.
Okay, again, another reminder, nasabi na rin naman ni Sheena that we will be posting the evaluation link later after the program. So meron tayong QR code na isa-scan or meron po kaming link na isa-send po sa ating chat box.
And during lunch break po, we encourage everyone to stay with us in the Zoom link while you have your lunch para you won't have to sign in and sign out again. So, Bryce.
Yep.
So ngayon, we will have a lot of speakers pa in the afternoon, no?
May dalawa pa. 2 interesting topics actually. And also yung mga presenters natin ng research, magaganda rin yung mga topics nila.
Yes, that's what I'm looking forward to actually. Because of the pandemic, it's not like before na that they can present it na in actual talaga, diba? So Zoom na lang, we have to adapt with the times. But I'm thankful talaga ako sa 600 participants na nandito. And hopefully next year we'll be able to see each other face to face. Yes, that's what I'm looking forward to.
Last time, maganda yung yung convention. Parang nasa, if I remember correctly, nasa Araneta, sa isang doon, sa isang hotel. Maganda, maraming tao.
Akala ko sa Araneta Coliseum. Concert pala.
Hotel sa Araneta ko ba?
Mali. Hotel pala.
Hotel, sir. Yes. No,
kala ko doon nag-concert si Bryce. Nakita niyo naman, di ba? Super talented ng partner ko.
Hinihingal pa nga ako.
Kaya nga.
Hinihingal pa talaga ako. Kaya mo lang yan.
Yes. Ang bilis ng costume change.
Yes.
I'm so impressed. So, ayun nga, lahat ng nurse. Kasi doon sa actual convention, we were also able to showcase the talents of the different nurses, diba? Yes. Because hindi lang tayo sa bedside magaling. Well, sila pala, wala akong talent. Sila pala, hindi lang sa bedside magaling, but also sa iba't ibang fields.
Yes. And also, ang yun yung kagandahan ng ating face-to-face. But ang kagandahan din ng ating Zoom is mas marami tayong naaabot, no?
Yes, we're able.
From other countries, merong from Bataan. So yung pag face-to-face kasi, hindi sila makapunta sa ganitong venue because of the travel,
Yes,
and
the cost.
Yes.
Ngayon, we were able to reach out to them in the comforts of their home. Meron pa nga tayo dito participants from Ornap, Ifugao.
Ang layo din ng Ifugao.
Yes.
Imagine, ibabiyahin nila yun. From Ifugao to Manila, medyo hassle.
But before, pre-pandemic, they really
may
effort talaga to go here in Manila. Nag-check-in pa sila sa hotel just to be able to attend the convention. We also have delegates from Tacloban, Urdaneta City, Iloilo City, Bacolod City.
Mayroon din tayo from Misamis University Medical Center, and also yung mga kapitbahay natin dito sa Lung Center of the Philippines and sa NKTI.
Hello to our neighbors. Yes, NKTI and Lung Center. We also have delegates from Cotabato City, Nueva Vizcaya, Tuguegarao, Iligan, Zamboanga, and Marawi.
Marawi, nalayo. Imagine kung sila magbabiyahe from their place, no? Pero convenient na rin tong naka-Zoom.
Yes, it's convenient and it's safe. But hopefully, iba pa rin kasi yung nakikita mo face to face, no? You can see the smiles on their faces. And we also have different participants from Batak City, Cavite, Camarines, Coronadal, Davao City, Cebu, San Fernando, La Union, Legazpi City, Bulacan, Kuala Lumpur, Malaysia. Hello.
Hello po.
Welcome, and I hope you're enjoying the webinar. We also have participants from Baguio City, Leyte, and Siquijor.
Hi, guys.
You. Hello.
So, we're done actually with the morning session, but before we proceed to our afternoon session, we will be serenaded, we'll be entertained by an intermission number and video presentation from our distinguished partners, Bibon. So now, let me introduce to you our guest for today, who will share his talent. He is a singer, an artist, an entrepreneur, and a registered nurse by profession. And I heard na former staff nurse ng Philippine Heart Center, if I'm correct.
Yes.
So he's also, many people said that he resembles Alden Richards. He is seen active on Kumu and other social media platforms. To serenade us live this afternoon, let us give a virtual warm of applause to Mr. J.R. Estudillo.
Ayun, hello. Thank you so much po, Sir Bryce. And to Ma'am, maraming salamat. Saan po ba? Pwede po ba ako dito or dito po? Sa gitna, okay. Ayun. And good morning pala, sorry. Good morning po sa lahat ng mga nurses natin na nanonood ngayon all over the world. No, kasi I heard kanina na may taga Sri Lanka and some parts of the world. So, ang daming nanonood ngayon. So, I'm kinakabahan. Wow. And grabe naman yung pa-intro na yung Alden Richards. Hindi naman. Thank you so much. And hello po sa lahat ng mga batch, ano ba kami? November 27, 2021 na batch dito sa Heart Center. Ayun, sana po magustuhan niyo yung first song ko para po sa inyong lahat. This song reminds me of sa lahat ng problema na pinagdadaanan natin ay we should always just keep going kasi sa dulo naman, 'di ba, alam naman natin yan at in every tunnel there's a rainbow. after it. So, sana po magustuhan ninyo. Here's Rainbow. DJ, pwede po. DJ. All right. Ulit hindi po Korean ha. But you didn't it's hard to breathe when all you know is the struggle of staying above the rise and water line. Where the skies fall open, the rain won't stop blowing, but you stuck out in the same old storm again. You hold tight to your umbrella, darling, I'm just trying to tell you that there's always been a rainbow hanging over your head. If you could see what I see, you'd be blinded by the colors, yellow, red, and orange and green, and these to really matters. Tie up the boat, take off your coat, and take a look around. Where the skies find you, the rain won't stop blowing, but you're stuck out in the same old storm again. You hold tight to your umbrella, 'cause darling, I'm just trying to tell you that there's always been a rainbow hanging over your head. Oh, tie up the boat, take off your coat, and take a look around. Everything is alright now, where the skies finally open, the rain stop raining, but you're stuck out in the same old storm again. Let go of your umbrella, 'cause darling, I'm just trying to tell you that there's always been a rainbow hanging over your head. Yeah, there's always been a rainbow hanging over your head. Thank you so much. Thank you, thank you. Can I request po na itaas konti yung music kasi hindi ko po masyado naririnig. Maraming salamat po. Ayun, sana po nagustuhan niyo. Medyo malungkot yung kanta pero it's giving us positivity, no? Na just keep on going, to just, you know, just fight whatever you are going through right now. So, ayun, yun ang importante, diba? Kapag pag may sakit tayo, dapat lumaban lang talaga tayo. Yan din yung mga pinopromote natin lagi as a nurse, diba? Na, you know, just focus on positivities in life. So, our next song is an OPM song sa mga, sino bang sa mga nanonood sa atin ngayon, sino ba ang fan ng ano dito, ng OPM? Can you press 1? Press 1. Ayan, sa lahat po ng here's an OPM song para po sa, para pwede ba akong makarinig ng palakpakan dito sa live audience natin? Ayan. para naman ma-hype tayo, di ba? Siyempre, iba yung feels dito sa harap kapag kumakanta ka. Dapat may energy din tayong nakukuha sa mga audience natin. And sa lahat po ng mga pumapalakpak sa kanilang mga ngayon o lugar, thank you guys so much. Here's an OPM song para sa lahat. Diyan sa taas, okay lang po ba kayo dyan? Hello po sa inyo ha. Mga tao pala ako hindi nakikinig. Alright, let's go. At pwede ko pong pataas ng music. Thank you so much.
Lahat sa buhay ko'y naglalaho. Lahat ay mga iaalay sa'yo. Basta't kasama kita, walang kailangan pa. Daranan na hanapin pa, basta't kasama kita. Basta't kasama kita, lahat magagawa, lahat ay maiaalay sa'yo. Basta't kasama kita, walang kailangan pa, wala nang hahanapin pa, basta't kasama kita. Wala nang hahanapin pa, basta't kasama kita.
Thank you so much. Maraming salamat po. Thank you so much, Philippine Arts Center. Ayun. Parang kulang yung energy natin. Palakpak naman po kayo dyan. Ayun. Thank you so much. Ano pong... welcome po for my first set. First set pala. More pa ba? Oh, sige. Ano bang meron doon? Ha? Ano ba meron doon? I think, meron pa bang isa dyan? Well, hindi ko na ano yun eh. Dalawang songs na talaga prepare ko guys para sa inyong lahat. Pero dahil po na I can say no, of course, dahil pamilya natin pa nandito. I think may ano ata ako dyan. May bang YouTube dito? Nag-YouTube na lang no? Toxic? Sige. Alright. Alam mo ba yun? Okay. Game. Ayan. Sa lahat ng mga... Alright. Ang taas na ito eh. Maybe can you say I'm gone? I go like you should know me. It's dangerous. I took a sip, never give me any dangerous. I'm living it. Too high, can't come down. Losing my head, spinning round and round. Do you feel me now? You're toxic, I'm slipping in the river, taste of your poison. Paradise, I'm addicted to. Don't you know that you're toxic? No. Yeah, I love what you do. Don't you know that you're toxic? Wala akong narinig. It's getting to give you up. I took a sip from the devil's cup. So calm down, losing my head, spinning round and round. Do you feel me now? Days of lips shining on the right. You're toxic, I'm slipping in the river. Days of your poison. Paradise, I'm addicted to. Don't you know that you're toxic? No. Yeah, I love what you do. Don't you know that you're toxic? Don't you know that you're toxic? So ito pag ano no? Hype yung music. No. Days of lips right. You're toxic, I'm slipping under the taste of your poison. Paradise, I'm addicted to you. Don't you know that you're toxic? No. Yeah, I love what you do. Don't you know that you're toxic? Intoxicate me now with your loving now. I think I'm ready now. Intoxicate me now with your loving now. I think I'm ready now. Intoxicate me now with your loving now. I think I'm ready now. Intoxicate me now with your loving now. I think I'm ready now. Intoxicate me now.
Thank you so much. Ay, maraming salamat po. Wow.
Sir, ito.
Thank you, JR. Thank you, thank you. Sa song renditions mo.
Thank you. Patunay.
Napakaganda, napakagaling.
Patunay na talented talaga lahat ng nurses.
Oo.
Yes.
Versatile.
Balita ako, lalaban si Bryce.
Pero yung maganda yung second song daw, basta't kasama kita. Yung isa toxic. Meron ka bang kasama sa... Ay, sige, basta kasama mo toxic?
Toxic, marami. Shout out to
Toxic?
Okay.
Team song ng mga nurses, toxic?
Toxic. Lalo na pag may pansin. Universal ata yun eh.
Again, thank you, Mr. Estudillo, J. Estudillo, for that wonderful song rendition. And now we would like to request our partners, be Brown, to play their video presentation. And kindly, sa ating mga participants, kindly stay tuned for our PM session. We will see you again at
1 p.m.
1 p.m.
Yes, you may take your lunch, but we hope that you won't log out.
Yes.
You'll just stay inside in the link na lang.
So, tuloy pa rin naman ng mga video presentations sa ipapalabas. So, please stay tuned.
Yes, thank you.
See you guys 1 p.m.
See you at 1 p.m.
The B. Brown Intracan Safety 3 closed IV catheter, making IV access safe and efficient from start to finish. Hold the clear flashback chamber with thumb and fingers on opposite sides behind the finger flanges so that needle flash is clearly visible. The finger flanges are designed to minimize touch contamination. B. Brown's proprietary universal bevel is a sharp needle that provides flexibility of insertion angles. The universal bevel creates a V-shaped tricuspid incision, resulting in a flexible pathway for easy and smooth catheter insertion. The result is greater comfort for patients and easier insertion for clinicians. The double flashback technology improves first stick success through quick visualization of both the needle flash and the catheter flash. Here's how the double flashback technology delivers this benefit. Upon insertion, the first flashback of blood, needle flash, is visible in the clear flashback chamber, confirming the needle tip is in the vein. Then the entire device, catheter and needle, is lowered and advanced slightly into the vein. Using the push-off plate on the catheter hub, the catheter is advanced forward, off the needle, into the vein. A second flashback, catheter flash, occurs between the catheter and the needle, confirming that the catheter is successfully in the vein. Once the catheter is advanced completely, the needle is withdrawn straight out of the hub in a controlled and continuous motion. The passive safety shield engages as the needle tip passes through the catheter hub. It deploys automatically and permanently shields the needle tip. This passive safety feature cannot be bypassed and is designed to protect against needle stick injuries. As the needle is withdrawn, The multi-access septum closes, controlling the flow of blood from the catheter hub. When a Luer connection is made, the multi-access septum opens, allowing flow in and out of the catheter. When a Luer accessory device is disconnected, the multi-access septum closes. The septum works multiple times to help prevent contact with the patient's blood. The integrated stabilization platform is designed to improve catheter stability and minimize movement within the vessel. The unique vein entry angle of the catheter hub is designed to prevent catheter kinking, and the ergonomic hub design allows for easy and aseptic connection of devices while keeping the Luer connection off the patient's skin. The stabilization platform allows for easy catheter securement and is designed to minimize catheter movement in the vessel. The stabilization platform's unique shape allows visualization of the insertion site. The removable vented flash plug provides additional versatility. It can be loosened to speed blood return during catheter insertion. The flash plug can be replaced with a syringe or blood collection access device. The B. Brown Intracan Safety 3 closed IV catheter, providing safe and efficient IV access from start to finish.
Sound check. Sound check. Sabi mo, sound check. Sound check. Sound check.
Ano pang backdrop mo?
May we request everyone to please settle into your seats. We will begin the afternoon session in 5 minutes.
Sound sound check.
All right, we would like to welcome again our participants, distinguished panel and speakers to this afternoon session of our convention. Allow me to introduce our speaker. She is Medical Specialist 3, assigned in the Division of Education, Training, and Research of Philippine Heart Center. She held various committees in the same institutions, such as co-chairman on Hospital Committee on Clinical Pathways acts as co-chairman of the Pharmacy and Therapeutics Committee and chairman of Records Management Improvement Committee. She became an assistant professor and faculty member of the Department of Pharmacology and College of Medicine at UERM MMCI from 2016 to 2019. She became a telemetry officer under the Division of Critical Care at Makati Medical Center from 2010 to 2013. Ladies and gentlemen, let us give a hand to the lecture entitled Beyond Grit, Embracing Clinical Pathway for the Prevention and Evaluation of Cardiovascular Disease. Let us all welcome Dr. Francois Marie Sarmiento.
Good afternoon, everyone. Thank you for inviting me to be a resource speaker in your convention this year. It is a great privilege to talk about clinical pathways in our field of specialty. The use of clinical pathways is relatively young in the country. However, I remember when we started creating clinical pathways for the Philippine Heart Center before, way back in 2012, one of the resources we used was the clinical pathway from our nursing service. So I assume that this valuable tool for healthcare quality is not new to you, but I still hope that I get to enlighten you some more on its significant role in the spectrum of cardiovascular disease prevention and evaluation. Let me start by defining a clinical pathway. A clinical pathway has been called by many names like care pathways, critical pathway, integrated care pathway, path of care, among others. A clinical pathway is a tool used to improve the delivery of quality health care. It aims to standardize the care we give to our patients with the same condition or undergoing a specified procedure. Its ultimate goal is to improve patient outcomes across all patients that received care. A clinical pathway is a detailed step-by-step patient path of care. There are many players involved in the care of the care of the patient, and the clinical pathway will include and specify the roles of the different disciplines involved, and most importantly, the care process that is specified in the clinical pathway based on the current evidence, guidelines, peer-reviewed trials and researches, and best practice of care. Clinical pathways were created because we want to optimize the outcomes of our patient in the setting of the hospital or home care. Basically, a clinical pathway will translate clinical practice guidelines supplemented by current studies, policies, best practice of care into a pathway of care for a particular diagnosis or procedure. Aside from using the clinical pathway to standardize care, it is also being used by hospitals to limit the use of unnecessary tests, procedures, or resources in the care of the patient. Ultimately, this will reflect as being more cost-effective to the patient while getting the best outcome of care that was given. And because it is evidence-based, its use will improve in the prescription of medications and therapies. And the patient will be referred to specialties in a timely manner or to the more appropriate level of care, thereby limiting the use of unnecessary resources and decreasing the overall cost of healthcare received. A pathway also has a significant role in researches and dissemination of new information to the healthcare team. And one of the fields of medicine that has greatly embraced its use is cardiovascular medicine. Cardiovascular conditions and procedures are popular clinical pathway topics because of the high volume of patients that we have and because most of our treatment and procedures are very costly, as well as we have matured clinical practice guidelines and evidence-based care in place already. This slide was taken from the Galen Healthcare Solution Lecture on Clinical Pathways. So their agency offers creating a system of clinical pathways into the centers hospital information system, and these are their most common examples of clinical pathways that they have encountered in their practice. As you can see from the slide in front of you, the most common conditions in the spectrum of cardiovascular disease are actually cardiovascular risk assessment or screening and the management of risk factors, which is the prevention for overt cardiovascular disease. However, here in the country, although a number of medical centers have already adapted the use of clinical pathways within their own centers, there are limited studies on its utilization, compliance, and effectiveness. In a review by Seguin et al., they looked for studies from Malaysia and Philippines on clinical pathways that are used for the evaluation and management of cardiovascular disease. Unfortunately, their study yielded only a handful, around 25 studies, and mostly the studies are from Malaysia. So in their study, they noted that there was an intolerance to change in the psychosocial behavior of Filipino and Malay hypertensives. The large gap in the use of evidence-based treatment strategy was not actually because of the underutilization of clinical pathways, but probably because we have not fully embraced the use of clinical pathways here in the country. So, does our country really need a clinical pathway for cardiovascular diseases? Of course, my answer will be a yes. Globally, cardiovascular disease, particularly ischemic heart disease, remains to be the number one cause of death, and approximately 8.9 million people die from coronary artery disease every year. And here in the country, even with the onslaught of COVID-19 in 2020, ischemic heart disease remains to be the number one killer disease across all age groups. And in the top 10 causes of death in the country, three kinds of cardiovascular diseases are included in the top five. Thus, it is important we have a tool to be able to deliver the proper evaluation and prevention for our patients against cardiovascular disease. So, can a clinical pathway help us with this problem? As we all know, uncontrolled hypertension is one of the most powerful risk factor for the development of cardiovascular disease. In the study done by Dr. Season, the Precision study, they found that 18% of Filipinos have hypertension. And unfortunately, almost two-thirds of them are poorly controlled. And yet, even with the accessibility of the clinical practice guidelines, literally by just clicking our fingertips, management of hypertension is still inadequate. For example, in his Precision study, most Filipino hypertensives were found to be on beta blockers. And during the time of this study, which was done in 2014, guidelines have already recommended different first-line antihypertensives and that beta blockers be reserved as first-line agents for hypertensive patients with heart disease or coronary artery disease. Second, there might be an over-requesting of laboratory and other screening tests for the evaluation of cardiovascular disease. Like for a young, healthy, active 35-year-old man with no significant risk factors for CAD, requesting for all these laboratory tests, even for screening, may be inappropriate and he might be just wasting his money away that he could have used for other treatment or for his personal life. Another issue that a clinical pathway can help with is the poor referral system and the level of care for our patients. Because of psychosocial, even financial factors, we understand that most of our kababayans do not seek proper medical help when needed. However, our primary healthcare units can be prompted if they use a well-drafted clinical pathway and they can properly advise patients when the need to seek specialized care arise. In this roadmap of pathway care of cardiovascular disease prevention of England, They emphasized as important interventions the screening and the system level of care that is appropriate for their patients so that they will be able to detect who are at risk for cardiovascular disease and treat them early so that they will have better outcomes and prevent heart attack, stroke, and organ damage like kidney failure, dementia, blindness, and even death from happening. Also, we often see patients in polydrug regimen, commonly in patients with hypertension. Maybe because the healthcare practitioner was focused on the drugs, the non-pharmacologic therapy such as lifestyle modification is being missed out in the management of the patient. A properly written evidence-based care clinical pathway will help in reminding the users of important therapies that should be included in the care of a patient with a particular condition or procedure. Medication or therapies that are not evidence-based or have weak recommendations from the experts will be excluded from the care. Thus, unnecessary therapies will be avoided. So, in fact, we become assured that even if we are giving the most cost effective treatment, we are ensured that we will produce better or even best outcomes for our patient. So in summary, let me show you a picture of a clinical pathway for the management of hypertension from the Pan American Health Organization. In their very nice, eye-catching, very easy to understand clinical pathway, as we can see, they have careful instructions on how to take blood pressure properly. Then the next step is to assess the cardiovascular risk of the patient. So the indications for initiating drug therapy is written, and even those patients that need to be looked after carefully, like the high-risk hypertensives, are indicated. The lifestyle modification therapies are also included in the pathway. So it surrounds the drug therapy order so that it means that they should continuously be recommended to the patients. And towards the end, a triaging up to the level of care is indicated to patients with poorly controlled blood pressure. And lastly, one of the most important parts of the clinical pathway is the description of the outcomes that the clinical pathway intends to achieve is also written here. I am towards the end of my lecture, and before I end, I would like to present one of our very own clinical pathways from the Philippine Heart Association Council for Rheumatic Fever, Rheumatic Heart Disease. So these pathways were written intended to increase the use of antibiotic prophylaxis like penicillin for our patients with rheumatic fever and rheumatic heart disease, ultimately to prevent the recurrence of rheumatic fever and to delay or even stop the progression to heart failure or the need for surgical intervention for those who have already rheumatic heart disease. This slide shows the different parts of the clinical pathway. We also made this clinical pathway as a registry tool as well as a research tool so that we'll be able to study the effectiveness of our therapy in preventing overt heart disease or heart failure among our Filipino patients who will be given penicillin injections or its alternative. So what the council did in coordination with the Rheumatic Foundation of the Philippines was to integrate this clinical pathway into a PhilHealth package, like an incentive for the patient, the physician, and the healthcare facility who will be using this pathway. Hopefully, with the integration into a special package with the PhilHealth, more Filipinos who have previous rheumatic fever or has active rheumatic heart disease can avail of this free antibiotic, the free benzathine penicillin injections or its oral alternative, and Included is an annual 2D echo so that we can prevent the progression of the heart disease, prevent heart failure from occurring, and limit the need for definitive intervention for these cardiac patients. So in summary, the value of a clinical pathway in the screening and prevention of cardiovascular disease is very obvious. It will work. It can be used to deliver better health outcomes to our patients, especially in our country wherein a majority of our patients are financially challenged. Early screening and prevention for cardiovascular disease in the most cost-effective and safe, and that is based on current evidence that is well written in a clinical pathway will be most helpful so that our healthcare practitioners in the primary care setting can easily use for their patients. But of course, somebody has to write and draft a clinical pathway first so that all these goals will be achieved. Thank you.
For the prevention and evaluation of cardiovascular diseases. Our next speaker for today is a nurse from Cotabato Regional and Medical Center. He's a graduate of Bachelor of Science in Nursing at CMFC Cotabato and an AB Biology student at SCC Midsayap Cotabato from 1992 to 1994. He was a certified level 5 cardiovascular care under the DOH Nurse Certification Program and certified ANSAP Level 4. To discuss on topic entitled Paving the Road from Heart to Heart, a Coronary Care Journey, ladies and gentlemen, Mr. Ronnie G. Villarosa.
Good day, everyone. Thank you for that kind introduction. I am delighted to be a part of this 21st annual convention of the Society of Cardiovascular Nurse Practitioners of the Philippines, Incorporated. Before going to my lecture proper, let me show you this picture. This is the facade of Cotabato Regional and Medical Center. And this is the Grand Mosque of Cotabato, officially the Sultan Haji Fazanal Bolkiah Mosque, and the second largest mosque in the Philippines, with the capacity to accommodate 15,000 people. And this is the aerial view of CRMC with a total land area of 10 hectares, a 600-bed capacity, which serves both the mainland Bangsamoro region and the central Mindanao of the Philippines. Well, the assigned topic to me is paving the road from heart to heart, a coronary care journey. And this is the topic outline. Number one, the concepts of critical care and intensive care, patient-focused approaches in the nursing care of patients in coronary care. Third, patient and family response to critical care. Fourth is benefits and challenges in coronary care nursing. For the objectives, after completing the session, the participants will be able to review the importance of critical care and intensive care. Second, utilize patient-focused approaches in the nursing care of patients in coronary care. Third, identify the needs of the patient's family and significant others in the critical care and plan appropriate nursing interventions to address these needs. And fourth, describe the benefits and challenges of critical care units and intensive care. Intensive care, also referred as a critical care, is a specialty which focuses on the management of critically ill patients who are at risk or have developed potentially life-threatening multi-organ failure of the body. And this involves holistic care of all aspects of critically ill patients, and this includes diagnosing, monitoring, treatment, and organ support for acute illness, patient safety, end-of-life care, ethics, and support in families. It is a life-saving and dynamic branch with the responsibility of managing the sickest of patients in hospital. And it plays an important part of healthcare system in the world, and it's one of the fastest growing medical fields, especially in terms of patients number. It is now slowly being felt and recognized all over the world, where a major challenge is to ensure adequate infrastructure, training, equipment, and funding for these newer members of the critical care arena. Patient-focused care involves designing healthcare services and around the needs of patients, and the goal is significantly improve the cost, quality, and service by reorganizing services around the needs of patients rather than around functional departments or profession. In many facilities, patient-focused care plans share a number of common elements, and they can vary significantly from one hospital to the next depending on the physical layout and available resources. And the following elements of patient-focused care plan is number one, patient clustering, which means patients with similar clinical needs are grouped into larger homogeneous patient care center, making it easier to match staff and services with patient needs. Second, redeployment of ancillary services. Services like radiology, respiratory therapy, and laboratory testing and decentralized and relocated so they are closer to the patient. Third is cross-training and multi-skilling tasks, and the job description are consolidated to reduce unproductive idle time, and staff are cross-trained to perform this task as multi-skilled employees. The fourth is patient care team. Each patient is assigned to a team of multi-skilled caregivers for the duration of a hospital stay. The fifth one is exemptional-based care management. Physicians, nurses, and other caregivers follow standardized protocols in treating patients chart when exemptions are made to the standardized care. The sixth is realignment of authority and accountability. The hospital hierarchy and performance indicators are reworked to reflect the shift in authority and accountability away from functional department directors to care center leaders. Or the patient-focused approaches in the nursing care of patients in coronary care. So there are patients admitted at the coronary care or CCU are faced with numerous challenges due to the difficult conditions and illnesses, the unknown environment, distance from relatives and friends, and exposure to aggressive care. Nurses in these wards also have to deal with environmental stress, high workload, shortage of staff, and difficult patient care conditions. This affects the nursing care process and can compromise the quality of care provided. Thus, patients is receiving unfavorable and disproportionate care. In the study conducted by Ferzo Karase, which participated by 7 patients with cardiovascular disease and 22 caregivers and effective strategies for implementing patient-centered care in cardiac care unit, an opportunity for change, they concluded that practical strategies for the implementation of patient care centered in coronary care unit revealed were at structural, process, and outcome levels to promote the quality care for cardiac care unit patients and improve patient satisfaction. Number one, structural strategies. Structure means the context in which services are provided and is prerequisite for facilitating processes and influencing outcomes to achieve patient care centered. So in here, expansion of team coordination. Teamwork was one of the most important. Implementation of patient care centered in teamwork, strong communication, collaboration, and leadership, and managerial commitment are required for service providers. It is also important to have managers who act as a role model for teamwork and actively involve employees in teamwork. So therefore, effective cooperation among professional groups is increasingly considered as an essential element in the implementation of patient care centered. Another thing is organizing nursing care. One of the factors that affects the quality of nursing care is the workload of nurses. Therefore, one of the most important management strategies to increase the quality of care is the use of labor division methods by nursing managers, especially head nurses. Regarding the division of labor, one of the nurse said, the role of nursing manager is very important. Given the limited facilities of the ward and the shortage of staff, nursing care should be organized in such a way that we can provide comprehensive and patient care centered for patients. Nurses have been assigned in many unnecessary tasks and correspondence along with tasks related to documentation and accreditation. And this has restricted them in doing their main tasks such as focusing on the patient, educating them, providing comprehensive care, and communicating with the patient's family. Regarding the organizational of care, one of the nurses said, the number of checklists has increased. A lot had been added to the staff work. Instead providing care to patients, the nurses have to deal with these issues. They are more involved in paperwork than staying at the patient's bedside. For the motivational mechanism, from the participant's point of view, using appropriate motivational mechanism aimed at the optimal implementation of patient care centered is an effective structural strategy. This, according to the participants, includes providing financial and moral support for employees, reducing their working hours, providing them with the necessary facilities in the workplace, and building empowerment and self-confidence in them. In this regard, one of the participants stated, in order to increase the motivation of nurses, the requested program should be considered. It is important that they are appreciated orally or in written form. When an employee does a positive job, and they should be appreciated and empowered because their empowerment increases their self-confidence and self-esteem. Another thing is the process strategies. So process is here defined as the core of giving and receiving services. And the process of care affects the outcome. The process also includes areas related to the interaction between patient and healthcare providers. In the study conducted, participants stated that communication is one of the most important aspects of nursing care. And many of the nurses' duties such as physical care of patients, emotional support too, and exchange of information with patients are not possible without communication. So to cultivate communication, they emphasize active listening for collecting information, application of the communicative skills, sharing information, and discussing care with the patient. Furthermore, the participants stated that effective communication provides respectful and compassionate care, that it includes flexibility in care and responding to the patient's preferences, needs, and values. This is done by affirming the patient's personal, cultural, religious, and spiritual values while expressing empathy and confidence when responding to the patient's feelings. Last is outcome strategies. Outcome is defined as the impact of services on the health status of patient and people. In this study, outcome shows the importance of implementation of patient care centered. Participants believe that factors that empower patients admitted to the CCU includes managing the patient's concerns, involving the patient in managing their illnesses, and maintaining continuity of care. For the patient and family response to critical care, so number one, statement of the participant, I would like nurses to take the time to listen to us and ask questions and encourage the patient to fully explain their condition. In this study, participants stated that communication is one of the most important aspects of nursing care. And many of the nurses' duties, such as physical care of patients, emotional support too, and exchange of information with patients are not possible without communication. So to cultivate communication, they emphasize active listening for collecting information, application of communicative skills, sharing information, and discussing care with the patient. And another statement of the participants for the healthcare provider, in order to be able to provide good care, we must examine the patient from all in angles and give them the opportunity to express their problems. So most participants stated that in order to provide patient care centered, it is very important to develop a holistic understanding in nurses. A nurse with a holistic attitude should take into account the psychological and emotional health of the patient so that she could facilitate the patient's physical treatment. This demands purposeful investigation and recognition of the patient. And another patient stated that I feel comfortable and happy when I see that my doctor is treating me like a friend. They or doctor should pay attention to the patient's opinion and problems when they visit them. The patient should be able to comment on their own treatment. So furthermore, the participants stated that effective communication provides respectful and compassionate care that includes flexibility in care and responding to patients' preferences, needs, and values, while expressing empathy and confidence and responding to the patient's feelings. And one of the patients commented on the importance of communication. It is therefore we must involve patients according to their capacity, and we must set the stage for that. There will be no cooperation without any agreement between the patient and the nurse. That is, if trust is established and we train the patient and they realize this, it leads to cooperation. So now patient empowerment begins with providing information, and education involves seeking information about illness or conditions and actively participating in care conditions. Increasing patients' involvement in self-care is a step towards permitting a person's sense of responsibility for their illness. Involvement in self-care involves the joint design of a care plan that includes aspects of joint decision-making, support, and goal setting, all of which contribute to clinical management, better health outcomes, and improved quality of patient care. And finally, to ensure of successful patient empowerment, continuity of care, and increased cooperation among patients and caregivers is important. And participants in the present study suggested that workload due to shortage in nursing staff increased the number of work shifts and increased number of documentation related to accreditation. So they also believe that tasks not related to nursing practice can reduce the relationship between nurses and patients and thus diminishing the quality of health care and the job motivation. According to the Mamodishan, nurses suffer from physical and mental fatigue due to hard work and numerous shifts, which runs counter to appropriate working conditions. Using an appropriate motivational mechanism is another strategy mentioned by the participants, and other solutions suggested that by participants included raising their salary in proportion to the expected workload and activities, reducing the number of working hours, appreciating and encouraging positive work of the staff, motivating the staff to improve their skills, and establishing a professional position and job independence in the workplace. In this regard, Ismaili found that, in the view of nurses, supporting and encouraging those who provide high-quality patient care centered can enhance positive behavior. And in fact, the study participants told that managers' ignorance of distinguishing employee at the workplace and lack of encouragement mechanisms were obstacles to promoting motivation and achieving patient care centered. Constantly, motivated nurses are more willing to take care of the patient, work with the other members of the treatment team, and provided better care services. They also have high verbal and behavioral skills in their work, as opposed to unmotivated and dissatisfied nurses who have little, if any, desire to provide quality nursing care. Therefore, creating a motivational and supportive atmosphere can lead to increased care outcomes. For the challenges in coronary care nursing, so nurses play as an integral role in the healthcare field, providing care to patients and filling leadership roles at hospitals, health systems, and other organizations. However, being a nurse is associated with big challenges. So here are the three major challenges. Number one is no breaks. Just like in the ER, ICU nurses must possess incredible physical and emotional stamina to keep up with the pace of the job. They must remain completely focused from the beginning of their shift to the end to ensure patient safety and be ready to manage any obstacles that may arise. Because of these demands, a major challenge of critical care nursing is the requirement to always be engaged, to be on, and this can be exhausting, especially since the stakes are so high. And one of the several patients' lives are frequent on the line, and it can lead to considerable fatigue. Number two is compassionate fatigue. So compassionate fatigue compared to ER nurses, ICU nurses typically manage with a small number of patients at once. However, These patients are often in the ICU for an extended period of time and required constant supervision. Because of this constant close contact, it's easy for the ICU nurses to become emotionally attached to the patients. ICU nurses are often a shoulder to cry on or to a person to confide in. However, one downside of this connection is the heightened feeling of loss when a patient does not make it. Unfortunately, because ICU patients are so unstable, this is not an uncommon outcome. Over time, compassionate fatigue may develop, a condition sometimes called secondary traumatic stress. ICU nurses are certainly not only class of professional who work experience this phenomenon. Other includes lawyers, veterinarians, police officers, journalists, therapists, and survivors of disasters of trauma. But the rigors of ICU nursing make the compassion fatigue like for nurses. What are the symptoms of compassion fatigue? So this includes feeling of hopeless. Over time, repeatedly losing patient can lead to a feeling of severe hopelessness, as if the constant hard work being done to help stabilize patient is ultimately fruitless. So this, of course, is not the case, but the feeling can be powerful. Another thing is negative attitude. This is constantly being exposed to death can result in habitual pessimism. Another thing is sleep issue. Many ICU nurses who experience compassionate fatigue find they have trouble sleeping or may experience nightmares. Third, stress and anxiety. So constant stress and anxiety are the two of the most common symptoms of compassionate fatigue. It is important to take note that not all nurses experience compassion fatigue and that is not a permanent condition. The third is nurse burnout. According to a study by the RN Network in 2017, more than half of working nurses in the United States have either considered or are currently considering leaving the profession. The study concluded that it's not because the work is not rewarding, but rather because the amount of the work required. When nurses reach this point, the condition is often called nurse burnout. So what are the factors that cause the nurse burnout? These are several factors that lead nurse burnout, which may include exposure to death. For ICU nurses, death is a constant reality that is either imminent for their patients or inevitable, spending long, tireless hours working to keep patients alive, only to have them pass away, and can be both overwhelming and stressful. While some nurses are able to compartmentalize this part of the job tending to the dying patient, others find their repeated exposure to fatal patients' outcomes is emotionally draining. Long shifts. Sometimes shifts may extend as long as 12 hours and possess little to no chance to take a break. Because patients are subject to constantly changing conditions and ICU nurses are responsible for monitoring their status and making their adjustments. Shifts can sometimes feel endless. Grieving family members, monitoring patients and patients' death can be a major source of burnout, but so can the subsequent grief of family members. An ICU nurse is one of the first point of contact available to family members, and they may express everything from fear to anger, which the ICU nurse must observe. There are necessary skills to overcome challenges. So the challenges posed to ICU nurses are significant, but most people who enter the profession have a greater than normal capacity for mental and physical stamina and find ways to make adjustments. The symptoms of burnout and compassionate fatigue are not permanent, and by leaning into the skills that makes an ICU nurse successful, they can be managed and eliminated. Number one is passion for the job. To some, passion for the work might not be nice, but not entirely necessary. For an ICU nurse, it's almost essential. The ICU floor is challenging and can be emotionally draining. But if a nurse nonetheless passionate about their work, they become able to work through the hard times and savor the good. Often, it's the little thing, like a kind word from family members or positive change in patient's health, that a passionate ICU nurse can leverage to find the strength to battle burnout. The second, technical know-how and ability. To work on the ICU floor requires comprehensive medical understanding and the ability to make the judgment on the fly. The deeper a nurse's understanding of medicine, the more confident he or she will feel when faced with a challenging situation. Third, organizational skills. While organization is important for an ER nurse, for an ICU nurse, it's absolutely vital. Managing several different patients simultaneously, all of whom requires different treatments, is a task that demands superlative organizational ability. If an ICU nurse becomes disorganized, the chances that she or he will miss a shift in a patient's condition increases. So organization is not only important in order to keep an ICU nurse on track, but it can also be difference between life and death. Support in self-care routines. It can be so easy for ICU nurses to get caught in treating patients that they forget to think about their own health. Anticipating that burnout may occur and taking preemptive self-care steps should be a practice of every ICU nurses engaged in. So the next are the rewards of being an ICU nurse. While the challenges posed to an ICU nurse may be significant, the emotional and professional rewards often match and exceed those difficulties. While the feeling of emotional rewards is subjective and may come from different sources of different for different nurses, some of the most universal upside include the following. Number one, constantly learning. ICU nurses quickly find that no two patients are alike, and what works to treat one might not work for another. This is sometimes frustrating through it creates daily opportunities for ICU nurses to learn more about medicine, the practice of critical care, and also how to provide emotional support to patients in need. Second, human to human connection. In here, one of the most challenging times during a nurse's times in the ICU results from connection made with patients, and it's those same connection that make the job so rewarding. And the number three is nurses in demand. According to a study conducted by the Bureau of Labor Statistics by 2020, the demand for nurses will increase by 36%. For nurses to excel in their positions, that means there are ample opportunities for career growth and also a lot of room for aspiring nurses to work. And I would like to share the activities conducted last January 23 to 28, 2022, in which this is considered as one of the milestone of Cotabato Regional and Medical Center for conducting the first cardiovascular surgical mission in partnership with the Philippine Heart Center. So the surgical mission has been a successful one. Out of 21 cases screened, only a total of 9 cases were catered. So the cases, 1 ASD, BSD closure, pulmonic stenosis, 1 BSD closure and ventricular septal defect, 3 BSD closure, and 4 PDA repair. And let's watch the video or a testimony of the mother.
Hello, good morning. I am Normera Naga Umpar and my baby is Siti Amara Umpar. Pakiramdam na naoperahan na siya. So beyond thankful, sobrang nagpapasalamat ako na nabigyan ng opportunity na masali kami sa ganitong medical mission. And masasabi ko sa lahat ng staff, super B as in wala akong masabi. Sobrang ang ganda ng treat nila sa amin dito, especially sa baby ko, sa mga nakikita ko sobrang walang masabi. Sobrang thankful ako. And mga experiences, wala naman, sobrang ano lang, parang normal lang na wala lang, hindi ko lang naisip na naoperahan yung baby ko. And wala na. Thank you. Sobrang salamat po sa lahat ng nag-sponsor, especially sa mga doctors na gumawa ng surgery, sa operation. Sobrang thankful po ako na nabigyan kami ng ganitong pagkakataon na maisali sa mga ganitong medical mission. Thank you po.
And for the next picture, this is the CRMC cath lab, at the same time considered as the hybrid OR. And the last slide, these are the picture of the post-op patient and their graduation date. For the last slide, lastly, the most beautiful things in the world cannot be seen or even touched. They must be felt with the heart, by Helen Keller. And that's end my presentation. Thank you for your kind attention. Stay safe and God bless everyone. Okay.
Thank you, Sir Ron. Again, may we request Sir Ron Villarosa and Dr. Fran Sarmiento to please turn on their cameras and unmute their microphones, as we will be going to our question and answer portion. For the participants or delegates, can you please key in your questions in the Q&A box found in your Zoom app. And our speakers are more than eager to answer your questions. So while waiting for the questions, meron tayo dito mga preset na questions. Sheena, first muna kay Doktora, Dr. Sarmiento, good afternoon po.
Good afternoon, everyone.
Doctor, regarding po dun sa clinical pathway, in the implementation of the clinical pathway, how can we measure effectiveness in terms of patient outcomes?
Okay, so we measure, when you make a clinical pathway, we have to make sure that we also make, yung binanggit kanina ni Sir Ron dun sa lecture niya, parang quality performance measures or the key performance in this indicators. So pwede doon maglalagay ka ng clinical outcomes. So for example, for this topic about evaluation and prevention, so pwede mong ilagay doon ilan ang na-detect mo na may hypertension, ilan na-detect mo na may overt na cardiovascular disease, so that you can measure if your clinical pathway was really effective in evaluating patients or screening patients for a certain disease. So you make those clinical performance measures or quality, like here's a heart center, we call them quality performance measures. So we measure the clinical outcomes as well as also the operational efficiency of your clinical pathway. So you want to measure if nasusunod nga yung compliant nga yung mga gumagamit sa pathway according to the measures or the standards that you placed in the pathway. So that's the primary key or tool to measure the effectiveness of your clinical pathway.
Thank you, Dr. Fran. For Mr. Ronnie Villarosa, we have a question from one of our participants. What are the most challenging factors that a cardiovascular nurse practitioner had encountered in a clinical setting that until now is unresolved, especially in both government and private sectors here in the Philippines?
Okay, so good afternoon, everyone. First of all, I'd like to congratulate the Society of Cardiovascular Nurse Practitioners of the Philippines on your 21st annual convention. So in my own opinion and in my experience, the most challenging factors, aside what I had mentioned a while ago, that the CV nurse practitioners had encountered in a clinical setting that until now that it's still unresolved. Number one is stress and professional burnout. So I think not only CV nurses, but other nurses assigned in other areas can experience this. So with these long hours and little sleep can affect each individual differently. And nurses often experience burnout and fatigue caused by working long hours and sometimes back-to-back shifts. So this can also result in some cases, and in them, making medical mistakes whilst on duty. So this is one of the nursing challenges we definitely want to avoid, as it can lead to being unable to work or even depression. And a tip on how to overcome this is take a deep breath. When you experience toxicity, um, make sure to have yung be optimistic. It's all in the mind. Sasabihin, kaya ko to. Just take a deep breath and make sure before you working week, you are well rested, getting at least 6 to 8 hours of sleep per day, and eating regular meals and taking some well-deserved overtime for yourself.
That is true, no? Especially during the COVID pandemic, the last 2 years.
Yes.
2 years ago, no?
We all
Parang
suffered burned
May talagang
out.
naka-burnout.
Yes.
So tama yung sinabi ni Sir Ron na talagang take a deep breath lang.
Yes, and take care of your mental health.
Yes.
You should take mental health breaks. And kaya natin to.
Yes. It's all about the mindset.
Yes.
For Dr. Again, Doc, you mentioned compliance po kanina. How can we ensure compliance or adherence of the clinical pathway in terms of implementation?
It's very hard to actually to impose even the use of or launching the clinical pathway itself. It's very hard. There are plenty of challenges that a center will face in just by launching. So according to studies, the number one cause of non-utilization or the poor use of clinical pathways, there is yung parang call this physician ayaw gamitin ng mga doctors. So once hindi na ginamit ng doctor, syempre hindi na gagamitin ng center. So to overcome this obstacle, one must make sure that when you're creating the clinical pathway, you involve the clinicians and the end users of the clinical pathway when you're making one. The number two reason is the end users, especially sa nurses na gagamit ng clinical pathways, is yung apprehension and the anxiety, skepticism also, and yung mindset na may bago na namang forms na gagamitin. So napipirmahan. So what we do there is that's why here in Heart Center, we have si Sir Yani and si Ma'am Mel, alam niyo naman yun, they go around to help you with the clinical pathway so that when you have some apprehension, you have some anxiety, you have questions about the clinical pathways, you can easily ask them so that the anxiety and yung paggamit ng clinical pathway is medyo napapacify so that the end users are not afraid. So even for us, for our fellows here in the center, we've been having a lot of problems with the use of the clinical pathway. So nagiging poor yung compliance. So what we did was we recently had an orientation. So hopefully, and we reassure them that if they have problems with the clinical pathway, they can approach me or any one of the committee members so that nawawala yung takot sa paggamit ng pathways. And for our nurses, plus yung clinical pathway, because it's a tool to help you in your documentation. Also, nakasulat na yung mga orders, so you don't need to transcribe yung mga stencil penmanship ng mga doctor. So it's actually a tool for everyone to help the orders to be easily read and mas claro, mas transparent all the path of care that will be delivered to the patient. So the compliance is actually part of, if you're able to encourage everyone to use the clinical pathway, tas nabawasan yung apprehension sa paggamit, then maybe the compliance will be easier to monitor. And also, another way to increase the compliance is that if you give incentives,
Okay, but it's very hard for us here in the government hospitals to give incentives for the end users. So that's why here in Heart Center, yung mga clinical pathways natin na nakakabit sa mga Z-benefit or sa may financial packages, yun ang nagiging mas magamit or mas nagagamit because of the incentive na kasama na sa financial package. But the others, we're still having a hard time to implement or for the others to even use kasi nga walang incentive involved. So we hope with the changing times, mas gumamit na ng clinical pathway and then we'll see an increase in the utilization and hopefully an increase in compliance.
Thank you, Dr. Fran. Actually, beneficial talaga yung pathway.
Yes.
Given natin. Kasi systematic na siya.
It's
Standardized. Yes. Organized yung orders.
Yes.
Kumbaga, ang magiging problem na talaga sa atin is yung forms. Pero it will benefit the physician, the nurses, and also the patients.
Yes,
syempre.
and I think it's very important the orientation and reorientation
Yes.
continuously of the end users of the pathway. That's why I would like to thank our coordinators, Sir Yani and Ma'am Mel, sa pagpapalo sa amin pag mali yung ginagawa namin sa pathway. Thank you so much. And for Sir Ronnie, last question. Patient-centered care is the cornerstone for critical care nurses to improve the quality of care. In spite of technological developments and advances, how can critical care nurses in the cardiac care units strengthen accountability and achieve patient satisfaction within the scope of patient-centered care?
Sir Ron, I think your
microphone's
turned off.
Sorry. Okay. So as what I've said a while ago, it's very important before a patient is admitted or once the patient is admitted, in order for to dig deeper on the side of the patient, what is their needs, it is very important for us nurses or even doctors to establish rapport to the patient. So from there, once we establish a rapport, the trust will be developed. And then by empowering a patient through expressing, once they express their concerns, because we already established a rapport and they gain trust from us, so it's easy for us to convince or to relay what is the best services or quality services that we can offer based on their needs or demands.
Thank you, Sir Ron and Dr. Fran.
Thank you po.
At this juncture, we would like to present the certificate of appreciation to our resource speakers. The society, before that pala, before we present, yes, we also have another speaker.
May isa pa tayong speaker, yes.
Yes, thank you.
Dr. Sarmiento, Sir Ron, thank
Sir
you so
Ron,
much.
thank you so much. Our next speaker is a former clinical instructor from University of Santo Tomas College of Nursing. He is also an assistant professor one of Taguig City University College of Education and previously assigned as an ICU nurse from Las Piñas Doctors Hospital. He is currently working as a clinical application specialist and CPT representative of B. Brown Medical Supplies Incorporated. Let us give a virtual warm applause to Mr. Francis Marie Singson, MAED, LPT, RN.
Good afternoon, dear nurses, and thank you for inviting me once again on your 21st annual convention with the theme spanning the spectrum from prevention and management of cardiovascular diseases. I am tasked to discuss about the implications of IVT standards to cardiovascular nursing practice. Being tuned in to the latest standards in IV therapy is a big plus, especially when taking care of delicate patients like cardiovascular patients. Thus, every will and awareness to follow this may help spell the difference between recovery and relapse, improvement and deterioration, life and loss of life. So our objective is to discuss the recent IVT updates valuable to the discipline of cardiovascular nursing. Diseases of the heart remains in the top 10 cause of death in the Philippines from January to November last year, according to the Philippine Statistics Authority, with ischemic disease being ranked as 1 or first, hypertensive diseases as 6, and other heart diseases being ranked as the 9th. Severe and critical cases need immediate attention and requires IV therapy as one of the pillars for medical management among hospitalized CV patients. And so with this, it is imperative that we know the latest in IV therapy so that we could provide the highest quality of patient care that all of our heart patients deserve. The reference I use, by the way, is the INS 2021. This is one of the most widely used references in infusion therapy. Globally, it provides strong recommendation for practice of infusion therapy with its evidence-based findings. It is actually updated every 5 years. So the last was on 2016 with comprising of 9 sections and 64 standards. But right now on its latest version, it has 9 sections and 66 standards with addition of VAD placement and catheter-associated skin injury. Those 2 standards were actually added. Due to the interest of time, I will just focus on several standards which have more bearing when it comes to the practice of cardiovascular nursing. So in no particular order, this would be medication verification, needleless connectors, administration set management, infusion medication and solution administration, and last but not the least would be the aseptic non-touch technique. Now we go to medication verification first, standard 13. It states there that we have to perform an independent double check by 2 clinicians for the organization selected high alert medications. High alert medications, or HAMs for short, bear a heightened risk of significant patient harm when they are used in error, and that is according to the definition of ISMP. So these errors in administration could lead from serious to fatal outcomes, especially when we are dealing with cardiac IV medications, which all of those are considered high alert medications. So they have to be treated like blood products. And here in this aspect, redundancy may have a negative connotation in general, but in this case, redundancies are actually beneficial. Next is, do not use color differentiation or color matching as the sole cue for product or medication identification. So this color coding can lead users to rely on the color alone rather than reading the label completely. So remember, we have a lot of look-alike cardiac medications in appearance and in spelling. Color coding should be secondary, but still the gold standard is to read completely the label. This is not only true for drugs and IV fluids, but for IV paraphernalia as well. Next is standard 18 on aseptic non-touch technique, or ANTT. So this is actually a more comprehensive framework for ensuring asepsis. So we have here some terminologies like key site, which refers to the portal of entry. Key part, so it's actually a part of the equipment that if contaminated and is likely to contaminate the patient as well. Examples would be the syringe tip, the male lower end, the spike of the IV set, and the injection needle. These are actually the parts that will make contact to the key sites. That's why they should be sterile to prevent contamination. Next would be the general aseptic field, refers to the decontaminated and disinfected procedure tray used to promote but not ensure asepsis. So any clean surface, an example would be a single-use procedure kit or barrier, okay, could also be used. And then critical aseptic field refers to our sterile tray, used to ensure, not only promote, but ensure asepsis. And then the last terminology would be the microcritical aseptic field, which refers to the small protective sterile surface that protects the key parts individually. Example would be the caps of the needle, the cap of the insertion spike, the cap of the lower end. So those are microcritical aseptic field. And the approaches to ANTP are divided into standard and surgical. So for the standard ANTP, so you have, it is actually used within a general aseptic field, and it's straightforward and short in duration. Usually the procedures that are performed at the point of care, for example, performing IV bolus, administration of intermittent infusions that are usually non-invasive, fall into this category. And then for the surgical, so it's used within a critical aseptic field, and it's also used when achieving asepsis is difficult. And usually the procedure that is involved here is long in duration. Examples would be surgical procedures that are done in the OR, and also some bedside procedures such as CVC insertion, which could be done at the bedside, cut down, okay, which may take longer than expected, and it's usually invasive, needs surgical ANTT approach. So the practice of asepsis to cardiac patients is pivotal because infection can put additional stress on the heart. So we have to be mindful when working with key sites like the insertion sites and key parts like the needleless ports and the IV catheter. Next would be standard 36 on needleless connectors. As discussed in the previous slide, needleless ports are considered key parts and must be protected at all times. And according to one study by Moreau and colleagues, the colonization of these needleless connections is considered the cause of 50% of post-insertion catheter-related infections. So the practice here is failure to disinfect these ports may lead to biofilm formation. That's why in order to prevent this catheter-associated bloodstream infections or CABCs, two types of disinfection may be performed to these ports. One would be active disinfection with the use of alcohol-based chlorhexidine swab pads. So here in active disinfection, effort is needed from the nurse to swab the port. And it's actually proven that this alcohol-based chlorhexidine lower or are associated with lower rates of CABCs, as well as the passive disinfection with caps containing 70% isopropyl alcohol. In passive disinfection, no active effort is required. You just have to cover the port with a cap and it will do its trick. And it's usually intended for open system needleless connectors. Meanwhile, for the swab pads, it's usually intended for closed system needleless connectors. For needleless connectors with which has an antimicrobial coating feature, so it still requires either active or passive disinfection, as it could not replace disinfection practices. Similar to the concept of gloving, you still need to perform hand hygiene even if you are wearing gloves. Next would be the administration set management. So we have three here. First is we have to consider the use of a new administration set when initiating a new concentration of a continuous IV medication. For example, if a previously run single dose nicardipine was doubled to concentrate the solution, so it is recommended to change the existing to a new volumetric set. So this prevents infusing any of the previous concentration remaining in the tubing, which could interact in the present tubing if we did not change it. It may constitute a medication error because of dilution issues. Next is to replace primary and secondary administration sets no more frequently than every 96 hours, but at least 7 days. From the previously recommended 96 hours in the 2016 version, it was extended to at least weekly, as long as it's continuously attached in the IV system. So this is true only for crystalloid and colloid IV sets, but not for lipids and blood products. Next, if the disconnection of a continuous or an intermittent infusion administration set is unavoidable, aseptically attach a new sterile compatible covering device to protect male lower ends on administration sets. So in relation to the 1 week rule, so this is only applicable when you have not exposed the administration set to the outside environment for prolonged periods of time. So this is an alternative. This is also an alternative wherein you may disconnect the administration set you are using for intermittent infusion, provided you have a new sterile cap, which is considered a microcritical aseptic field to cover the male lower end of the IV set. So you should not use the old cap because it is considered to be unsterile already. And then the last would be standard 59 on infusion, medication, and solution administration. So it states that we have to consider infusion of approximately 25 ml of a primary solution at the conclusion of the medication to ensure all of the medication is flushed through the administration set. So here, 25 ml of fluid usually covers already the entire length of the administration set, plus if there are additional extension tubings applied. So the medications inside the tubing, when not flushed, is tantamount to under medication, as well as when flushed late, it may lead to loss of potency. So this could also be an alternative to standard 43 when change of a new set due to a change of concentration is not feasible. And of course, the rate of flushing should be the same as the computed flow rate of the medication, again, to avoid medication error. For the takeaways, the highest standards of practice should be observed when performing intravenous administration of cardiac medications, and standards of IV related to infection control should be institutionalized to improve outcomes of cardiovascular patients, shorten hospital stay, and decrease morbidity and mortality. This ends my presentation. Thank you for listening.
Thank you, Mr. Singson, for that interesting lecture. At this point, we would like to open the floor for your questions if there are any. It looks like Mr. Francis's discussion has been really clear and
Clear
we,
naman.
yes,
Clear naman yung nagiging
yes, we do not have any questions.
So far, wala pa. Pero kung meron pa rin kayong questions, you can type in our Q&A box. Tapos meron din naman kaming mga staff na can answer your questions. And also yung mga panelists din, pwede na lang sagutin yung inyong mga questions later.
And meron lang may isa lang question kanina to answer your question. Yes, Philippine Heart Center is looking for nurses. You can kindly send an email to phccareers1@gmail.com or contact telephone number 925-2401, local 3816, and look for Miss Brooke. Join us now. We want you to be one of us. So now at this juncture, we would like to present the certificate of appreciation to our resource speakers. The Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated would like to award the certificate of appreciation to Francois May A. Sarmiento, MD, in grateful recognition of her invaluable contribution as resource speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th May of May in the year of our Lord 2022, signed Jesus Ferdinand B. Peralta, RN, Chairperson of the Scvnppi 21st Annual Convention, and Janine L. Comendador, RN DDM, President of Scvnppi.
Another certificate is given to Sir Ronnie G. Villarosa, Certificate of Appreciation in grateful recognition of his invaluable contribution as resource speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th day of May in the year of our Lord 2022. Signed, Jesus Ferdinand B. Peralta, RN, Chairperson of the Scvnppi 21st Annual Convention, and Janine L. Comendador, RN DDM, the President of the Scvnppi.
Last but not the least, the Society of Cardiovascular Nurse Practitioners of the Philippines Incorporated would like to award the Certificate of Appreciation to Francis Marie Singson, MAED, LPT, RN, in grateful recognition of his invaluable contribution as speaker during the 21st Scvnppi Annual Convention with the theme Spanning the Spectrum from Prevention and Management of Cardiovascular Diseases, given this 18th day of May in the year of our Lord 2022. Signed, Jesus Ferdinand B. Peralta, RN, Chairperson Scvnppi 21st Annual Convention, and Janine L. Comendador, RN DDM, President of Scvnppi. Again, thank you to all our speakers.
Thank you po. It is an honor for us to introduce to you today, and I'm very proud of this, that the 2% we have a presentation for research, the presenters for the research study. Our first research is to be presented by Mr. Mark Augustus Fabriag, RN MSN, a staff nurse from the Philippine Heart Center. His research topic is about the development and use of structured electronic pamphlet for Patients Mobile App, or STEP app, on the self-care activity outcomes of coronary artery bypass graft patients. Another research presenter is Mr. Alexis Ibahay, RN MAN, again a staff nurse from the Philippine Heart Center. His research topic is about creative art and focused therapy, or craft, to reduce anxiety level of preoperative patients in the medical surgical units of the Philippine Heart Center. Please let us give them a virtual warm of applause.
Hello everyone, I am Mark Augustus Fabriel, presenting the research study of the Medical Surgical 1 Division of the Nursing Services of the Philippine Heart Center entitled The Development and Use of a Structured Electronic Pamphlet for Patients Mobile App or Step Up on the Self-Reactivity Outcomes of Coronary Artery Bypass Graft Patients. Cardiovascular disease, including coronary artery disease, remains to be the leading cause of death in the Philippines, with 15% mortality rate in 2018. Based on the data from the Philippine Heart Center, 4,110 patients were admitted due to coronary artery disease, while 924 coronary artery bypass graft procedures performed in 2018. Although CABG poses a low mortality rate, recovery after surgery is still crucial to patients. In one study, a delayed physical recovery post-operatively was observed in 50 to 60% of patients. Several studies revealed that health education has resulted in better cardiovascular health index items. Health promotion as an intervention to prevent cardiovascular complications is also being influenced with the advances in technology. Therefore, it is with utmost importance to conduct a study on developing a mobile application that provides relevant information and assistance to patients in self-care management. This study generally aims to develop the step up and determine the association between its use to the self-reactivity outcomes of CABG patients. Quasi-experimental research design was utilized in this study to determine the impact of step-up use on the self-reactivities of CABG patients. The study was conducted from October to December 2021 in the medical surgical wards of the Philippine Heart Center that cater CABG patients. The target population includes patients with coronary artery disease scheduled for coronary artery bypass graft surgery. The researchers utilized a total enumeration sampling technique in which the whole population is being considered in the study. Using the G-power, a minimum of 42 participants are required for the study. Respondents included in the study were at least 19 years old, scheduled for coronary artery bypass graft procedure, with mobile electronic device that can access internet, and were technology literate. Patients who are required to extend the stay in the ICUs need to be transferred to another healthcare institution with certain conditions that prohibit them from using their mobile devices, and who refuses to participate were excluded in the study. The self-care activity performance evaluation tool was used in the study to evaluate the self-care activities of patients post-operatively. It contains 10 statements and uses a 5-point Likert scale. The tool was adapted from the study, the effect of preoperative health education plan on post-operative self-care activities of post-cholecystectomy patients by Madrilejas et al. In 2014. To determine the use of step-up, the system usability scale was utilized. It contains 10 questions and uses a 4-point Likert scale. This tool was adapted from the article, The System Usability Scale, Past, Present, Future by Lewis in 2018. All research instruments were self-administered and accessible in the step-up. Here are the phases of the app development. The step-up, which is the main intervention, underwent validation from IT experts, cardiologists, and from a small group of patients prior to the actual data collection. So what are the results of the study? A total of 42 respondents participated in the study. Data shows that most of the respondents belong to the age group of 51 years old and above, male and married. Of the respondents, over half of them were college graduate, and 31% are retired from employment. Self-care activities of patients were assessed post-operatively at ward and compared against the self-care activities post-operatively on the day of discharge. Generally, there is an observable trend of values in the illustration. With a p-value of less than 0.001, there is a significant increase in the respondents' self-care activities from ward post-operatively to the day of discharge. Respondents also evaluated the step-up on the day of discharge. Majority of the respondents strongly agreed that step-up is easy to use to the point that they would use this frequently. Most of the respondents believe that most people would learn to use the app quickly. On the other hand, many respondents disagreed that step-up is very cumbersome or awkward to use. Besides, most of them did not agree that the mobile app is unnecessarily complex, which they would not require any technical support. Nevertheless, StepUp had an excellent usability in terms of the overall score. The researchers analyzed that for every increase in the self-reactivity performance score, there is a decrease in the system usability skill score. With Spearman correlation coefficient of negative 0.1035, the researchers concluded that there is a weak negative association between the use of StepUp and the self-care activity outcomes of garbage patients. Statistically, the association of the two variables is not significant, at a p-value of 0.514. The result may be affected by a smaller sample size. According to studies with a bigger sample size, there is a positive association between the use of mobile health apps and self-management. Thus, large-scale study on the use of StepUp and self-care activity outcomes may be conducted in the future. From this study, conclusions were derived. StepUp was introduced to cabbage patients at ward post-operatively. During this time, self-care of patients was found to be effective. On the day of discharge, self-care of post-cabbage patients had improved into extremely effective. From this study, it was revealed that StepUp is easy to use, and people can learn it quickly. In totality, this study reports that StepUp has an excellent usability in self-care activities of patients who underwent cabbage. Furthermore, it was concluded that there is a weak negative association between the self-care activity performance and system usability scores. The association between StepUp and self-care activity of post-cabbage patients is not significant. With the results, recommendations were enumerated. Integrating mobile health apps, including StepUp in patient education systems, would increase awareness on different cardiovascular diseases. In addition to health teachings, StepUp may be utilized in surgical care and discharge plans to help prevent occurrence of complications and readmissions post-cabbage. The researchers also believe that there still need to conduct a large-scale study to know more of the benefits of using mobile application in recovery. Furthermore, potential risks of mobile apps and factors that affect the use of mobile apps may be examined by future researchers. You can install the app now. Just scan the QR code and tap the notification on your mobile phone. Ladies and gentlemen, on behalf of the Philippine Heart Center Nursing Services, we would like to say thank you for taking your time in listening to us.
Imagine yourself lying in the hospital bed. The doctor tells you that you're about to undergo an OR procedure. How would you feel? Mind blowing, right? In behalf of Karen Almorade and Philip Murada, I am here to represent our research on creative art and focus therapy, or CRAFT program, effects on anxiety among the preoperative cardiovascular patients of the Philippine Heart Center. Preoperative phase is considered one of the toughest times for our patients. Indeed, it is a stressful event, and identification of anxiety is essential for healthcare workers to intervene. In relation to this, the CRAFT program was created. So, what is its effect on reducing anxiety level among preoperative patients? That is the question. For our method, this is a quasi-experimental utilizing simple random sampling. So basically, it's controlled versus interventional, mixed methods, qualitative, quantitative, triangulation, utilizing design thinking, which included empathizing, defining, ideate, prototype, and tests. So in design thinking, we thought of a design which best suit the process. It took 5 phases. Phase 1 is pure collage. The second is music and art. The third phase included 3 groups and 3 tests. Phase 4 is a 5-choice art. And finally, the craft program. As of the moment, it is in the 5th phase of the project and has 3 interventional choices, namely mandala art, free painting, and letter to self. The results showed there were a total of 84 respondents, 46 interventional and 38 controlled, and 15 others were excluded in the study. The study provided 2 cutoff in terms of level anxiety. At level 39, no significance was noted. At level 22, we found out that when combining both intervention and control groups would have a significant result. 5 emerging themes were generated. The first theme, self-reflection from the procedure. This explains that the activity provided them the opportunity to express themselves and presented them an outlet to reflect on their personal experiences. This further flourished due to some themes, facilitates a positive view in life, and nourishing what is important. The second theme was the diversion of attention from the procedure. This sprung from the different forms associated with attention deflection through diversionary activities. Material diversion, focus diversion, and outlet diversion were the 3 sub-themes. The third theme was mixed emotions. The expressed feelings of the respondents portrayed a sense of semi-ambivalence, non-constant wave of feeling, joy, hope, and bargaining were the 2 sub-themes. Then the submission of self to higher being, the acknowledgement of God, and the sense of surrender. And finally, the conscious forgetting of the upcoming procedure, the suppression of the idea that their operation is swiftly approaching. To make this presentation interactive, we have simply summarized and restructured the triangulation result that is basing from the objectives of this research, key concepts that we have compared the qualitative data, the quantitative data, and other data sources or nonverbal cues. So what exactly is the effect of craft in comparison? To start answering this question in a general scale, let's go back to the 3 factors and compare them side by side. The responses from the qualitative data, the respondents verbalize a positive effect in general from the craft program. The quantitative result, however, showed a contrast. The comparison result of the state rate anxiety intervention showed a p-value of 0.2482, which means that there is no significance in cutoff 39. In cutoff 22, on the other hand, the overall data showed a p-value of 0.0196, which depicts that when combining both interventional and non-interventional groups, there is a significant effect. In search for the factors which may influence the finding, The researchers reviewed notes and recordings. We observed that the following may have a significant impact. Number one is environmental noise. The second is client's interpretation. These factors were further explained by Sarniak, the 9 types of biases which may influence the research despite the measures. Zurich, in a study, The Effects of Art in Surgical Patients, showed a significant effect with a variable in number. More so, some patients showed more effects to pain, anxiety, systolic BP, heart rate in both interventional and control group. In comparison with our study, the mentioned parameters were omitted from the protocol. Similarly, the study of Barasan in 2018 in a study on Mandala, which showed a p-value of 0.12 for the interventional and 0.08 in the control group, however, showed a decrease